And another very important thing again here is the patient is a very young patient, and patient had developed problems during pregnancy. And when the patient has developed problems during pregnancy and young patient, 32 years, you don't expect her to have aortic valvular heart disease, isn't it? Because aortic valvular heart disease, even if it is a congenital bicuspid valve, it usually presents after 30 years. The first presentation itself, maybe after 40 years. And if it is a sclerotic aortic valve, it presents after 50 years. So that way you can always, in the exam, when you are asked, you may always say it may be mitral valvular heart disease because of these following reasons. Because you have not examined the patient, you don't know what kind of a murmur is there or what auscultatory findings are there in for this patient. And without that, you can definitely say probably mitral stenosis or mitral stenosis with regurgitation. It can be a complex valvular heart disease. So that you can always say, because there are two things. One is complex valvular heart disease, mixed valvular heart disease as far as rheumatic heart disease is concerned. Complex valvular heart disease is having the same valve having both regurgitation and stenosis, like mitral stenosis with regurgitation. Mixed valvular heart disease is patient having a mitral valvular heart disease with aortic valvular heart disease. So that is a mixed valvular. So patients can have complex valvular heart disease and also mixed valvular heart disease, which you cannot make out from the history itself, isn't it? So unless the patient tells you what is the diagnosis. So that is why that is a very important thing you should always inquire from the patient. So keep it in mind when you present during your exams. If you get a mitral stenosis patient, hope you both of you will get a mitral stenosis patient as a long case. It becomes easy for you to answer. So definitely you can go through all this. Okay. So one more thing I just want to tell for all the students who are listening. So see, I told yesterday that only a few of the cases we keep for long cases or short cases. So make a note of what all the things you want to ask in the history, what all the things you want to examine, what all the investigations you want to do. In briefly points, you make a note of all these and take this into the exam hall, and just before entering, you can just go through all these, not for theory, for practicals I'm talking about. You will have an idea. 4 or 5 times if you have read, that will be there. Even if you just close your eyes, all those points will come to in your, because then you can take the history very rapidly. Very fast, what all the things you just have to ask in the history. So 1, 2, 3, 4, 5, you just ask and then you just note down. That will be, and what all the things to examine, and it will be very fast. You can make out, and also write what investigations you want to make for this particular patient. And also these things you write down in your whatever the case sheet that is supplied to you in the exam, so that it will become very easy. You are already written. Once you have written, it becomes easy for you to even see that and then tell there. And especially the normal values you write down there, because there won't be any confusion for you when you are asked about the normal values and the abnormal values. So these, once you have made this, so your job sitting in front of the examiner becomes easy. So you will not be anxious or distressed or whatever you can call it. So you can, just sail through the discussion there. Okay, so again, like yesterday, you present your examination findings today also. We'll just go through your examination findings. After sharing that, again, you take it off from the screen and then you, yes. Okay.
Okay, sir. Sure, sir.
One of you present the examination findings for all the students. Okay.
General examination. Patient is conscious oriented and cooperative. Height 150 centimeters. Weight 52 kgs. BMI 20.8 kgs per meter square. Patient is moderately built and nourished. There is no pallor, ictus, clubbing, cyanosis, lipidopathy, or pedal edema. There are no markers of infective endocarditis. Vitals. Pulse rate is 72 beats per minute. Irregular with pulse deficit of 20 per minute. Low volume pulse and a normal in character. No radio delay or no radiofemoral delay. All peripheral pulses were felt. Blood pressure 100/60 millimeters mercury measured in right upper limb in supine position. Respiratory rate 20 beats per minute. Thoracoabdominal type. Saturation 98% in room air. JVP was not elevated. Med score was less than 4. Temperature normothermic. Airway examination, normal facial symmetry. Bilateral nasal patency was normal. Normal range of neck movements. Mouth opening was more than 3 finger breadth. Mentoid distance 4 centimeters. Malambatic class 2. No loose tooth and missing tooth. Upper lip bite test grade 1. Spine examination. Skin of the spine is normal. Spinous pulse is palpable. No deformity. System examination. Patient was examined in the sitting position. Cardiovascular system examination. Inspection. Trachea appears to be in the midline. Apical pulse was not visible. No precardial bulge. No visible punctations or dilated veins over the chest. No scar, sinus, or bony deformities. On palpation, apex beat was felt in the left fifth intercostal space, half inch medial to the mid-clavicular line. Thrill was felt in the mitral area in the left lateral position during expiration. There was no parasternal leave. There was no chest wall tenderness. Carotids were normal. On percussion, cardiac borders were percussive. On auscultation, in the mitral area, loud S1 was heard, followed by normal S2. Popping snap was heard, and a low-pitched rough rumbling mid-diastolic murmur of grade 4 intensity was heard with the patient in left lateral position, with the bell of the stethoscope heard better during expiration, and it was not radiating. S1 and S2 was heard normal in all other areas, like tricuspid, aortic, and pulmonary areas. Other system examination, respiratory system, trachea is in midline, upper respiratory system normal, lower respiratory system air entry equal on both sides, no added sounds. Central nervous system examination, normal higher mental functions, pupils bilateral 2 mm reacting to light, power 5/5 in all 4 limbs, bilateral plantar flexor, no focal neurological deficit. Abdominal examination, abdomen is soft, no tenderness, no acromegaly, no free fluid. Final summary, a 36-year-old female with complaints of breathlessness on exertion for past 3 months with the palpitation for 1 month and worsening of NEHA in the last 2 weeks with irregular pulse and mid-diastolic murmur on expiration. Most probably mitral stenosis of rheumatic origin in atrial fibrillation, not in a cardiac failure with no features suggestive of infective endocarditis.
Okay, now we'll stop sharing. Okay. Kaushik, the examination was fine. One thing is, to start with, the patient is conscious, oriented, and cooperative. Just before that, all these patients, respiratory disease patients and cardiac patients, you should always first say whether the patient is comfortably sitting or comfortably lying down, because that becomes very important. Suppose why it's very important to tell that whether patient is comfortably lying down or not. Suppose if the patient, she is comfortably lying down, what does it imply?
Implies that she does not have any breathlessness.
Isn't it?
No
So,
active
no
orthopnea.
Yes. There is no orthopnea. The severity of dyspnea, you can always tell that there is no orthopnea at present. And patient is also maybe comfortably sitting. And also say whether accessory muscles of respiration are active or not. There only you can always tell. Because what happens to these patients with mitral stenosis as far as the lung? Yesterday we briefly discussed also, the lung compliance always comes down. Once the lung compliance comes down, the work of breathing increases. So once the work of breathing increases, even at rest, they may have some amount of, sort of increasing their work of breathing. So accessory muscles of respiration may be active. So that's what you'll have to mention initially. How as soon as you look at the patient, how the patient appears, whether she's using her accessory muscles of respiration or not, isn't it? She may not be totally breathless, but you can see the sternocleidomastoid tone is high. So that shows there is increase in work of breathing for her, isn't it? So that shows that there is slightly more, maybe moderate to severe mitral stenosis may be there if she is a mitral stenotic patient. So that is one thing. Second thing is you have written about height in centimeters 158. So what are the implications of height as far as anesthesiologist is concerned? Why height is important for you? 1, 2, 3, 4 points for height and anesthesia.
Sir, for giving spinal anesthesia, sir, if the patient is well built and well height is there, you can give the
no spinal.
dosage.
You go with the dose as far as the height of the patient. I don't think, except in cesarean section, definitely you go with the height, because in cesarean section, if the height is less than 150 centimeters, you go for 1.4 ml of bupivacaine heavy. If the height is between 150 to 175 centimeters, you go for 1.8 ml of bupivacaine heavy, 0.5%. If the height is more than 170 centimeters, then you go for 2.4 ml of bupivacaine, 0.5% heavy. So 1.4 ml, 1.8 ml, 2.4 ml. That is only in cesarean sections, not for routine spinal anesthesia for non-pregnant patients. Okay, one accepted. What are the other implications of height and anesthesia?
Sir, to select the size of the double lumen tube, sir.
Yeah, very good. Less than 160 and more than 160 for females.
170 centimeters.
Less than 170 and more than, okay, second point, very good. What is the third one? Very important when you maintain the patient. Tidal volume calculation. Very important. Nowadays, tidal volume has to be calculated based on the height of the patient. So the formula is, that 50 plus 2.3 multiplied by height in inches minus 60. For males, and for females, it is 45.5 plus 2.3 into height in inches minus 60. So this formula you have to use whether the patient is on a mechanical ventilation in ICU or mechanical ventilation during perioperative period, because you usually don't go for higher tidal volumes now. And
Yes,
tidal volume, you have to really calculate based on the height only. That is called as, appropriate body weight for calculating the tidal volume. It is called appropriate body weight for calculating the tidal volume based on the height, because lung size depends on the height of the patient. Lung size does not depend on the weight of the patient. Suppose if a morbidly obese patient is there, what happens to the size of the lung?
Decreases, sir. Decreases.
Isn't the compliance is decreased?
Decreases compliance.
The fat in front and also the abdominal fat and the diaphragm is being pushed, the lungs become small. So suppose if you 150 centimeters and 100 kgs, if you go with 100 kgs, then definitely you will produce a barotrauma instantly, isn't it? So that is another very important thing. So why I wanted to something suddenly you may be asked, height and anesthesia. So very important. Again, in especially pediatric age group, height in centimeters divided by 20 is the size of the internal diameter of the endotracheal tube. For example, now let us say 100 centimeters is the child height or length, you can say, because many times if it's able to stand, you can measure the height, otherwise length. So divided by 20. So 5 millimeter endotracheal tube internal diameter you take. So that's how it is very important. Of course, afterwards the weight, body mass index, importance for calculating the drug dose. Then again, these things again were very, very important. So pallor, is pallor important in these patients to really know?
Yes, sir. Because if pallor is the patient anemic, sir.
Yeah.
So
anemia means, yesterday we discussed the compensatory heart rate will increase and they'll go for a higher level of dyspnea, isn't it? So that is why pallor is very important. And again, when you are examining the pallor, you can always look for whether it is mild, moderate, or severe. 1+, 2+, or 3+. You know how to, know what is 1+, what is 2+, what is 3+.
No, sir.
If only conjunctiva is pale, like you just look at the conjunctiva. Whereas the mucous membrane, like if you ask the patient to put out her tongue and the palate, they are not so pale. The skin is not pale, the nails are not pale. It is a mild pallor, 1+, you can say. That means in a male patient, it may be just about less than 13 and above 9 grams of hemoglobin. That is what. Anything less than 13 in males and anything less than 12 in females is called as anemia. So then if there is mucous membrane is also involved of pallor, then it is moderate. But if again nails are involved and the skin color, for example, very pale, the palms and the whole skin, especially in chronic renal failure, from a distance, you know that it's a chronic renal failure patient. Severe anemia will be there. That means the hemoglobin may be around 5 or less than 5 grams. So that's how, when you write down, if pallor is there, write down whether it is 1+, 2+, or 3+. Another thing you have written is about jaundice. So can these patients with mitral stenosis, can they have jaundice?
In case of right heart failure, sir, when they have hepatic congestion, they can have.
Yeah, very good. So if they have a chronic mitral stenosis involving even the right heart and right heart failure, so back pressure, so hepatic enlargement is there. So then gradually the hepatic dysfunction also will start. Then bilirubin may increase. Ascites, bilirubin may increase. So that is why that is important. Then again, cyanosis. Can they have cyanosis? All patients with cardiac failure can have cyanosis, isn't it?
Yes.
If they have developed a right heart failure, they can have what kind of a cyanosis? They have a central cyanosis or a peripheral cyanosis?
Central cyanosis.
It has to be central cyanosis, isn't it? So what kind of hypoxia they would have? Because various types of hypoxia is there. If a patient has cardiac failure, what kind of hypoxia? Because it is hypoxia is there.
Yes.
Anemic hypoxia.
Anoxic hypoxia.
Stagnant hypoxia. And P50 hypoxia. There are 5 types of hypoxia. In that, which hypoxia is with that?
Anoxic hypoxia, sir.
Stagnant hypoxia. Blood is not flowing easily, isn't it? It is called as stagnant. Any cardiac failure, the DO2 will not be able to meet the VO2 because of decreased flow. So that is why there will be an imbalance between DO2, VO2, and the patient will have hypoxia and cyanosis can occur. So that is another very important thing. And clubbing you have written. Suppose you had seen about 15 days back, this patient did not have clubbing. And yesterday you examined her, she has developed clubbing. Does it imply something to you?
Pulmonary hypertension could have set it, sir.
No, pulmonary hypertension will not produce clubbing.
Congestion. Pulmonary congestion, sir.
Infective endocarditis. So if the patient develops infective endocarditis, she can develop clubbing also. So that is one of the, because next you have written, there are no signs of infective endocarditis. One of the signs of infective endocarditis is development of clubbing. So which was not there and the patient has developed clubbing. It's a very important, plus fever, isn't it? And other things are also nodules and other things are also there. Hematura, splenomegaly, and a change in the character of the murmur. So all these are signs of infective endocarditis. And if a patient has infective endocarditis, for example, now that's what I was telling you. Yesterday you examined, today the patient is supposed to undergo surgery. Yesterday you found patient to have fever and also clubbing. Will you accept the patient for today surgery or you won't accept?
No, sir, you won't accept, sir.
You won't accept because infective endocarditis is an active cardiac condition, very dangerous. Mortality is very high if you accept these patients for an elective procedure. So that's how clubbing becomes so important. This is again the common question that is asked in your examination. Of course, pedal edema is another thing. So where do you examine for pedal edema? Where exactly?
In the shin, sir. Bony prominence, shin.
Shin is a big thing, isn't it? A long shin from knee joint to the ankle joint. Yeah, the shin. Where exactly?
Medial malleolus, sir.
How much above medial malleolus?
2 to 3 centimeters above the medial malleolus, sir.
Usually 1 inch above the medial malleolus. how much of what duration of pressure you will be applying?
Sir, we'll apply a constant pressure for 5 to 10 seconds, sir.
At least 30 seconds pressure. Kaushik is using his common sense, like yesterday I was telling about. Good. So about 30 seconds you apply, and there has to be a pitting edema. And where else you look for the edema in these patients?
Sir, in the different regions like sacrum.
Especially, the lumbar and sacral regions for us, because let us say that the patient has also cardiac failure and she is not moving around. So then you don't find edema in the pedal edema may not be there in the feet. There may be edema in the back, and that is again very important for us because that may obliterate your spines, and it may be a difficult spinal anesthesia, epidural anesthesia you will have to give. Okay, coming to these are okay, fine. The vitals, as you have written, pulse rate is 72 per minute. Again, patient is in atrial fibrillation, but 72 per minute, well controlled. So because yesterday we were discussing about digoxin, when do you say that digoxin has got optimized the rate response of ventricle? The dose is fine, whatever the dose.
And the heart rate is less than 70. 62.
And 70, no. It's 72, that means she's not optimized, is it? I said yesterday that heart rate has to be 60 to 80. 60 to 80 heart rate. And one more thing is, suppose if moderate exercise should not increase the heart rate by more than 10 beats per minute. Moderate exercise, like you ask the patient to climb one flight of stairs, 20 steps, 6 inches apart. So you ask her to climb that slowly, let it be very slowly only. And you again check with a pulse oximeter, what is the pulse rate? And if it was 70 before, now it has gone only up to 80. That means it is an optimal dose. And she is very well, the heart rate, left ventricular response is very well optimized with your digoxin. So that is another very important thing you should always look for. Of course, irregular pulse deficit. Again, Kaushik, how do you look for pulse deficit? This is again a common exam question, though hardly nowadays it matters because, atrial fibrillation by ECG, my pulse irregular, you will be knowing. So because there can be other, conditions where you can have irregular pulse. Can you just tell other conditions where you can have irregular pulse? Other than AF. No, multiple ectopics. Isn't it? Whenever multiple atrial ectopic, junctional ectopic, or even VPCs, ventricular premature contractions, and coming occasionally or coming frequently, then also you can have irregular pulse, isn't it? When you can have a regularly irregular pulse?
Bigeminy, trigeminy.
Very good. So bigeminy, trigeminy, anywhere else, any other condition? I'll give you a clue, heart blocks. Which kind of heart block you can have a regularly irregular?
Morbid type 2 heart block.
Both type 1 and type 2. Both type 1 and type 2 will have a regular missing of a ventricular complex with the preservation of the P wave or atrial complex. It will be there, it will be quite regular. And sometimes in atrial flutter, you can have regularly irregular heart rate. So these are some of the things. Okay, so I was asking you pulse deficit. How do you make out the pulse deficit?
We calculate. We calculate the heart rate and pulse rate simultaneously for a period of 1 minute.
One person want to calculate the heart rate and one person want to
calculate the pulse rate, sir. The difference.
So how many persons to be examining?
2, sir.
2. That is again very important because many of the students will try to tell that I'll keep the stethoscope over the patient's precardium and also I'll be palpating the pulse. For the same minute, you cannot, count at 2 places. Our brain, unless we have, right hemisphere can count the precardium, the left hemisphere can count the pulse rate. Otherwise, it is not just. So that is what you have to say. And anything more than 10 is significant. Pulse deficit. And cardio pulse deficit, it is always called as. So that is another thing. And unnecessarily don't mention radial delay, radiofemoral delay and all. How many patients you have seen? Do you really look for radial delay and radiofemoral delay? You don't look for, isn't it? Unless it is a coarctation of aorta or something. And then because, suddenly they'll ask you what are the conditions where you can have radial or radiofemoral delay and you say coarctation and the entire discussion can go towards coarctation of aorta, which you are not prepared for, isn't it? You are mentally not prepared for answering about coarctation of aorta. So you need not have to mention that. Okay. So another thing you have written about all peripheral pulses are felt. Okay, Shruti, why it's important? Why should you feel?
Because we can rule out thromboembolism if any, sir.
Very good. Because, that is another very important thing in any peripheral arterial disease patients or in mitral stenotic patients where you expect thromboembolism in the peripheral vessels, because it becomes so important. For example, let us say you have not examined and the left side radial pulse is not palpable. It has happened to one of our fellow students when I was a postgraduate. So actually, she had not examined the patient's peripheral pulses. The left is a peripheral arterial disease patient. Left pulse was not palpable. She gave spinal, and left side she tried to palpate and there was no pulse. She was so much agitated. She shouted cardiac arrest. And unfortunately, she ran away from the place also. That she should not have done. That is different. That's the reason why you should be very careful. So it is always better to palpate all. What are the peripheral pulses you will be palpating, Kaushik?
Sir, radial artery, sir.
That you will definitely palpate both radial arteries.
Yes, sir. Last one is Peds artery.
Oh, upper limb you just tell. Brachial artery you don't palpate.
Brachial artery.
It's the peripheral artery only.
Yes, sir.
Brachial artery, radial artery, ulnar artery.
Ulnar artery. Okay,
because Allen's test, definitely you will have to go for ulnar artery also. Okay, then dorsalis pedis, popliteal artery,
yes,
femoral artery,
temporal artery,
posterior tibial artery. So these are, because these are all we usually ask. Suddenly we'll ask you when you are talking, we can even stop you there and then ask you, okay, what are the peripheral pulses you will be palpating for? So once you are mentally knowing about this, you can answer very easily and rapidly. Okay. Another very common thing is, yesterday we discussed about the blood pressure. So you have to monitor or not monitor. You have to record the blood pressure, measure the blood pressure in lying down and standing. Wait 2-3 minutes and then record the blood pressure in the standing. Allow sufficient time for the compensatory effects to take place. What compensatory effects will occur once one stands? What happens? Now, suddenly there is the venous return will come down, isn't it?
Yes.
How the body will manage the blood pressures?
So when the patient stands, the peripheral pooling of the bed will be there, sir. So there is a hypovolemia is there. Blood volume decreases. Then the baroreceptor
very good
will and the signal sent to the lymph. Yes, sir.
Will sense and then increases sympathetic activity. So heart rate will increase.
Increases heart rate.
For in autonomic neuropathy tests, isn't it? Standing test, CAN test, cardiac autonomic neuropathy. So heart rate will increase. The venous tone will increase of the lower limbs so that the blood is pushed up. And that is why you may have to wait for about 2 to 3 minutes and then you record the pressure. That is one thing. Again, another thing is about JVP. So did you really examine the JVP or just written?
Yes, we examined, sir.
What position you will be examining the JVP?
At
semi-recumbent position,
45 degrees.
45-degree angle, isn't it? 45 degree of the spine to the table.
Yes.
So why this 45 degree? Why not 60 degrees? Why not less than 45? There is again one more common question that you can be asked regarding JVP. Why this 45? And another thing is, when you are examining, you always, take Manubrium sterni as one of the landmark points. And above the landmark, above Manubrium sterni, you will record, isn't it? One scale at the top level of the jugular venous pulse. One scale horizontally you place at the level of the Manubrium sterni, and the distance between these two you are going to measure. Again, why Manubrium sterni?
Because distance from the Manubrium sternum to the right atrium will be 5 centimeters, sir.
No, that is depth.
Depth, yes.
You're not asking about the depth of right atrium from Manubrium sterni. Why you take one of the landmarks as a Manubrium sterni for measuring JVP, jugular venous pulse? Okay, if you don't know, I'll answer because time is not that much. So you see, if you see older Hutchison's clinical methods, beautiful figures have been given. the jugular venous pulse, the level of jugular venous pulse, it is JVP, it is not pressure. That is another very important thing you should always. CVP is central venous pressure. JVP is jugular venous pulse. You always look for the level of jugular venous pulse. Jugular venous pulse level is always at the level of manubrium sternum, whatever may be the position of the patient. So at 45 degrees, manubrium sterni and clavicle are at the same level. If the JVP is raised, jugular venous pulse is raised, it will be above the clavicle, isn't it? So that only you can visualize. Otherwise, 45 degrees angle, you're not supposed to visualize, usually the jugular venous pulse. Maybe just about 1 centimeter, it may be visualized in normal people. But if it is raised, it will be at least 3 or 4 centimeter elevated. So because it has to be at the level of manubrium, now it is elevated. You are looking at 45 degrees angle, it should be at the same level as manubrium and clavicle are at the same level. So now you just want to see how much it is elevated above the manubrium. That is why manubrium sterni is taken as one of the landmark points there. And probably if you add another 5 or 6 centimeters, you may get a CVP about that, usually. But usually we don't consider it as CVP, but JVP is entirely different. Okay, that is the reason why you always measure jugular venous pulse at 45 degrees angle. So this is again very important. You just, if you can get it, Walter Hutchison, beautiful figures are there. I used to take the photograph of that and then show to my students, especially when I was in Mysore Medical College. And another thing, METs you have written in, why do you write down METs in examination? It's actually, how do you get the METs? How do you get this METs, whether it is 4 or?
We get it in history.
History, isn't it? By going in for, the Duke's Activity Status Index, that is a DASI, Duke's Activity Status Index. There is a questionnaire there, and you start asking those questions, and based on the questions, you have to derive actually the METs, isn't it? So there are, points are given for those activities by Duke. That is the Duke Activity Status Index. So finally, you get a sum of all these points. So you have to multiply this sum of points by 0.43 plus 9.1 divided by 3.5, you get METs. That's how actually you have to get the METs from Duke's Activity Status Index. So otherwise, many times, okay, if the patient is able to climb 2 flights of stairs, it is above 4, isn't it? Otherwise, also sometimes, in respiratory system, we calculate VO2 max. VO2 max also, isn't it? What is VO2 max?
Oxygen consumption, sir.
The maximum amount of oxygen that is consumed for a particular activity, isn't it? So once you know VO2 max, how do you calculate the, the METs? Just divide by 3.5. If you have about 20 VO2 max, 20 ml per minute, that is. So just divide by 2.5, you get the whatever the mark is there. Okay. So that's how you always, but METs, you should always bring it in history and not as the examination findings. Okay, that is one more thing. Then, of course, airway examination and all we will discuss when we discuss about difficult airways. And spine examination is fine. So coming to cardiovascular system examination. So you have examined the trachea. Definitely, that is very, very important. Why do you first examine trachea for cardiovascular system examination?
We check the tracheas in the midline, sir.
Yeah. Why that is important? Whether it is line or whether it's deviated.
Sir, if the patient develops a pulmonary edema or anything, there is a shift of the
left atrial
enlargement also will be there, sir.
No. Always, you first rule out any mediastinal shift is there or not. If there is a mediastinal shift, your apical impulse also will shift, isn't it? So you just rule out any mediastinal shift is there or not. And once the mediastinal shift is not there, so then you can know the position of the apical impulse and then comment on the position of the apical impulse. Okay.
Yes.
So that is why you always look for first the trachea and then you look for the apical impulse. Okay. So now again apical impulse, you have written that. Okay, let's go for palpation. So I've written that it is in the fifth intercostal space, half an inch medial to the midclavicular line. Okay, so what is the importance of this particular thing?
If there is an associated right ventricular hypertrophy, it could be pushed downwards, sir.
Right ventricular
hypertrophy could be pushed downwards, sir.
Downwards? No, right ventricular hypertrophy may push it slightly laterally. That's all.
Laterally, okay, sir.
Otherwise, it is always the left ventricular hypertrophy which will push it downwards and outwards. Downwards and outwards, it is always the left ventricular hypertrophy. So just one more thing, Mukhtar is there?
Yes.
Mukhtar,
yes, sir. Yes,
I got a call and everything is, this become contracted, the whatever, the Zoom. So how to again bring back to the full screen? It is at a corner. I received a call. I cut
Okay,
it.
sir. Sir, I didn't see, sir. Can you please tell again?
Pardon? No, I got a call, Mukhtar.
Okay, sir.
So what happened on the screen, the our images have gone to one side at a corner. Small.
Okay. So you're using a laptop or
Laptop.
You can double click the screen, sir.
Double click over?
On that screen, the small screen.
No, I tried all those.
Is there any extra access towards the side?
Pardon?
There will be the corner of the.
Yeah, that is there, but I'm clicking that also and somehow it's okay. But if I had able to see the whole big screen, that would have been better.
So do you want to join the meeting, sir?
No, no problem. We'll continue like this only. Okay. We're discussing about the apical impulse. So tell me, you have written apical impulse is in the fifth intercostal space. So why, suppose if it was in the sixth intercostal space and lateral to the midclavicular line, what you would have thought about?
Left ventricular hypertrophy, sir.
Left ventricular hypertrophy and left ventricular hypertrophy can be there in this patient?
No, sir.
Yes,
So suppose patient also has a mitral regurgitation.
yes, sir.
Or patient also has got an aortic stenosis. Because you have not examined the patient, auscultated.
Yes,
so still there is a possibility that the patient may have, that is how apical impulse becomes important. The position of the apical impulse. Whether it is normal or slightly maybe shifted towards the left, but in the same intercostal space, fifth intercostal space. But if it is shifted downwards and outwards, and it is heaving in nature, then definitely it's a left ventricular hypertrophy. So both in mitral regurgitation and aortic stenosis or aortic incompetence, it can be, isn't it? Because in mitral regurgitation, what sort of a left ventricular hypertrophy can be there?
Eccentric.
Pardon?
Eccentric left ventricular hypertrophy, sir.
Eccentric, if it is because volume overload. Volume overload, both in aortic incompetence and aortic mitral regurgitation, there will be volume overload. So eccentric hypertrophy. Otherwise, if it is a pressure overload like hypertension or aortic stenosis, usually a concentric hypertrophy. But both the apical impulse will be shifted downwards and outwards. Okay, one more important thing here is the character of the apical impulse. because that is only by feeling only you have to talk about. You have not written any character of the apical impulse, isn't it? You have just written
yes.
it is felt. What are the different kinds of apical impulse by palpation you can make out?
Sir, tapping type
normal
of
apical impulse. How will be the normal apical impulse? Normal apical impulse is, it will just lift your finger and goes back. Just lifts your finger and goes back. So if it is tapping in nature, usually you can find in cases it will not lift at all. It will just touch and then go. It will touch your finger and then go. That is because the left ventricle is not contracting very well, isn't it? Because the volume inside the left ventricle is so low. And myocardial contractility depends on the left ventricular end-diastolic fiber length. So which law?
Frank-Starling
law. Very good. So because the volume is low, so contractility is less. So it may just come and then touch and then. That is what. And many times some people also say that it may be because of the loud first start sound, you get this type of apical impulse, tapping apical impulse. Then you have a forceful apical impulse, especially in all hyperdynamic circulations. Forceful. So it is lifted and again immediately goes back. It doesn't sustain there.
Yes, sir.
That is called as forceful. And heaving apical impulse is it lifts, sustains for a few milliseconds and then goes.
Yes, sir.
So forceful, sustained apical impulse is heaving apical impulse. That will, tell you that there is left ventricular hypertrophy. So describe the character of the apical impulse. Don't just say whether it is just felt there or not. Okay. Another thing you have written is about the thrill there. What is thrill?
Palpable murmur is a thrill, sir.
A palpable murmur is a thrill. And you will be grading the murmur, isn't it?
Yes,
so once thrill is present, what is the grade of the murmur?
Grade 4, sir.
Grade 4. Very good. So we'll come to that when we discuss about the murmur. Then one more thing, you had not felt in the left, second intercostal space, what is this left second intercostal space? What area?
Pulmonary area, sir.
Pulmonary area. Palpate there?
No.
You will be palpating for what?
Pulmonary arterial hypertension, sir.
Isn't it? So P2. Normally, P2 may not be palpable. So once the pulmonary hypertension is there, P2 can be palpable. So a palpable P2 also will give you an indication that there is, pulmonary
hypertension.
So you have not mentioned. So don't forget to mention and don't forget to examine P2 palpable.
Okay, sir.
And again, parasternal heave. So how do you look for the parasternal heave?
We use the
we keep the ulnar border of the hand on the patient's pulmonary area and will
left lower sternal region.
Left sternal border. Parallel to left sternal border. Like that. And then see whether it gets lifted with every right ventricular systole. That gives you an indication that there is right ventricular hypertrophy. So if the apical impulse is heaving in nature, left ventricular hypertrophy. If there is parasternal heave, it is right ventricular hypertrophy. So now here you have written that the parasternal heave is absent. What does it indicate?
Indicates there's no left ventricle or right ventricular hypertrophy.
Sir, there is no right ventricular hypertrophy, sir.
Parasternal heave is only right ventricle.
Right ventricular
That
hypertrophy.
means the pulmonary hypertension is not so severe enough to produce right ventricular hypertrophy. It may be there, but still that's not significant enough to produce a parasternal heave. So, okay, those things are fine. And the other thing is regarding the auscultation. Okay, in the auscultation, you have written first about loud first heart sound. What is the cause for loud first heart sound? Before that, we just talk about the pathophysiology of mitral stenosis. Just tell me in detail about the pathophysiology of mitral stenosis.
There's a mechanical obstruction because of a stenosed mitral valve, sir. Because of which the blood flowing from the left atrium to the right left ventricle will be reduced, sir.
Okay.
So there'll be more blood pooling in the left atrium, which will cause an increase in the left atrial pressure. So this left atrial pressure will get, it will transmit as a back pressure to the pulmonary venous system. And that will cause a secondary increase in pulmonary arterial hypertension, pulmonary interstitial edema.
Pulmonary venous blood pressure will increase passively.
Venous blood pressure will increase.
First thing you see, the pulmonary venous pressure. Before that, actually, there are a lot of compensatory measures the body will be taking, isn't it? Once there is a narrowing of the mitral valve, so what is the first compensatory measure the body will take? The left atrial hypertrophy, isn't it?
Left atrial hypertrophy. Yes.
The thickness of the left atrium tries to push by increasing its gradient, pressure gradient. So in the meantime, it starts thickening because it has to work more. That is the first compensatory mechanism. And once that compensatory mechanism is exhausted, now the blood will start staying back, producing more left atrial pressure. Now the blood gets into the pulmonary venous system. So what is the first compensatory mechanism in the venous system? The pressures will rise, is it?
Pressures will rise, yes.
No, pressures will not rise first. What is first thing that occurs? What is inverse mustache sign or antler sign?
Yes, sir.
Suppletion of the veins. Suppletion of the veins, sir.
Yeah, because normally the veins in the upper zones of the lung, they are collapsed because they are above the heart. The alveolar pressure is much higher than the arteriolar and venous pressures. These veins will open up. They'll accommodate this extra blood. And that is what you see in the X-ray chest as the reverse mustache sign. The vascularity in the upper zones of the lung, normally there is hardly any vascularity. It is more translucent because more vascular, and it starts from the hilar region, isn't it? So that is how, the pulmonary veins will dilate in the upper zones, producing accommodation of this extra blood. So again, the pulmonary venous pressures will not increase. Once this gets exhausted, the pulmonary venous pressure will start increasing. And that is a post-capillary increase, isn't it? Because, pulmonary artery, then capillaries, then the pulmonary veins. This capillary increase, passive increase in the pressures. Now, afterwards, as you said, it is transmitted to the pulmonary arteries, and there pulmonary arterial hypertension occurs, and permanent changes in the pulmonary arteries will occur. What are these permanent changes in the pulmonary arteries? So that is intimal hyperplasia and medial hypertrophy. The media that is containing the muscular layer of the pulmonary arteries, the hypertrophy, and the intimal hyperplasia occurs, that will narrow the lumen. Once the lumen narrows based on Hagen-Poiseuille's law, the flow decreases by 4th power.
Yes, sir. Radius.
But pressure also increases by 4th power.
Yes.
Automatically, once the area decreases. That's how, the pressure gradient starts increasing. In the meantime, fluid will start shifting from the pulmonary venous system or arterial system into the lung and also into the alveoli. And especially when the patient exerts, because the back pressure, sudden increase in the back pressure, fluid shift, and this will produce, some amount of pulmonary edema and transient pulmonary edema, because once the patient takes rest, so it may come down. So this is what the patient will have dyspnea, isn't it? So all these things, and afterwards pulmonary arterial pressure sustained increase. This is actually a compensatory mechanism to prevent fluid going into the interstitium of the lung. Otherwise, even at rest, it would be going when such a high left atrial pressure starts. So by thickening of the pulmonary arteries, so it will not allow the fluid to enter from the pulmonary arterial system into the lungs. So that way it is another compensatory mechanism. And then right ventricular hypertrophy, and also
then shift to
atrial hypertrophy.
Right
and right failure, isn't it? So these are the things that occur proximal to the valve. What happens distal to the valve? Distal to the mitral valve.
Left ventricle.
So in 30% of the patients, even the papillary muscles and cardiac tendineae may be involved in the inflammation of rheumatic fever. So the hypotonia of the left ventricle may be there already. In remaining 70% of the patients, gradually over some time, there can be hypotonia can occur because of the disuse, because the small volume is there. Otherwise, the stroke volume will be a fixed stroke volume.
Fixed stroke volume, sir.
Low fixed stroke volume, so low fixed cardiac output. So these are the things. So why these patients you have written about the mid-diastolic murmur, rough rumbling mid-diastolic murmur. So why this particular mid-diastolic murmur in case of mitral stenotic patient? Why not early diastolic murmur? Why not late diastolic? Late diastolic also will be there, of course. But why mid-diastolic? Why not early diastolic?
There is the mitral valve opens in the pressure volume loop. The mitral valve opens. Between the mitral valve opening and mitral valve closure, there is the diastolic filling, sir. So
that is there. Now, when mitral valve opens, is it immediately after the aortic valve closes, or there is some delay?
There is some delay,
sir.
And what do you call that delay?
Isovolumic
relaxation phase, isn't it? So immediately it will not open. That is again A2OS gap is another very important thing. Normally it will be more than 80 milliseconds. That delay, even many times it can be around 120 milliseconds, 0.12 seconds. So that delay will be there between the aortic closure and the mitral valve. So almost the mitral valve is not opening immediately as the ventricle is relaxing or going into diastole, isn't it? So that's how the murmur starts slightly later, as soon as the first heart sound occurs, or as soon as the opening snap occurs, as soon as the mitral valve will open. So it is almost in the middle of the diastole. So it can be even still earlier because of the, so much of pressure is there in the left atrium, and as soon as the aortic valve closes, the mitral valve can open with a snap. That is what A2OS gap can come down, even to less than 80 milliseconds. That is again one of the signs of severity, of the mitral valvular heart disease. So that is the reason why the murmur will be there. And what kind of a murmur? Is it a crescendo, decrescendo, or decrescendo murmur? Or what kind of a murmur is it? Initially, the murmur is high intensity coming down, or the murmur is initially it's a low intensity going up. What is the rapid filling phase? Early rapid, as soon as the valve opens, there is a rapid filling phase.
Yes, sir. It's high intensity followed by
so
low,
intensity will be very high. So it's a decrescendo.
Decreases.
And again, the left atrium contracts. That again produces some amount of turbulence because the blood is passing across the narrowed valve. Whenever turbulence occurs, definitely Reynolds number, once it crosses more than 2000, you can hear the murmur. Otherwise, normal flows you will not be able to hear the murmur. So that will produce another murmur, which is or increase in the intensity of the murmur, that is called as a presystolic accentuation. So will you hear presystolic accentuation in this patient?
No, sir, will not hear, sir.
Why you don't hear?
Because the patient is not a normal patient, is an AF, sir.
That means there is no proper contractility of the atria, isn't it? That is the reason patient, you will not find. That is why it's very important when you find a pulse which is irregularly irregular, don't say presystolic accentuation is there, as you see in the book.
Yes.
Okay. Yes. And another important thing is loud first heart sound. Why loud first heart sound?
Because of the thickening of the leaflets, and there is a sudden closing of the mitral valve. So there's a loud response, sir, and it shows the pliability of the valve, sir.
And because mitral valve is forcibly closed against the pressure gradient, because so much of pressure is there in the left atrium still, because blood is still there, isn't it? So it is forcibly closed. That produces, with lengthening of the valves, rigid valves, so that produces a loud murmur. When the murmur will not be loud, when it is soft.
And it's a calcific.
One is calcific.
Mitral stenosis.
Okay. When there is mitral regurgitation is there.
Mitral regurgitation.
But it is not closing at all properly, isn't it? So it may not produce any loud sound. Or third is when severe stenosis is there. Then the murmur becomes soft. Murmur also becomes soft. Loudness of the first heart sound also comes down. So this is again very important because if it is a calcified valve, so the patient will not be fit for
balloon mitral valvuloplasty.
yeah, balloon commissurotomy.
Mitral.
Patient will not be fit. So that is how this particular loudness of the first heart sound becomes very important for you in the exam. So when you are talking about. So the other thing about the duration of murmur is again important.
Yes.
Why duration of murmur is important?
The duration is more, the severity is more, sir, because there is a
Yeah.
very narrow region.
Correct. So longer the duration, more is the severe. Because finally you have to come to a conclusion whether the diagnosis is moderately severe or severe, isn't it? So for that duration, suppose if as soon as the mitral valve opens, the murmur starts and it keeps going till the second heart sound, isn't it? So
Yes,
that shows that definitely there is duration is longer. So that is what because it is a diastolic murmur, isn't it? Once it opens till the first heart sound, it continues. So that shows that the severity is higher. Okay, that is another very important thing. And you have to describe the murmur. Like one is you describe the site of the murmur, where the maximum intensity is there. That is important again to know from where the murmur is arising. That's why the mitral murmurs will arise from where? Maximum intensity will be where? Apex, because they are arising in the ventricle. Because the blood is flowing into the ventricle and that is producing the turbulence. And it is best heard, as you said, during inspiration or expiration.
Expiration, sir.
All left-sided murmurs are better heard in expiration. All right-sided murmurs are better heard in inspiration. That is an important thing you should know about. The third thing is the grading of the murmur.
Yes.
How do you grade these murmurs?
Grade as 1, 2, 3, 4, sir. Grade 1 will be very soft. Grade 2 will be soft. Grade 3 will be loud. Grade 4 will be loud with trills.
These are which type of murmurs you grade? Only 4 grades.
Diastolic, sir.
Diastolic. Yes. Systolic murmurs?
Grade as 6.
Yeah, 5 and 6 are also there.
Yes, sir.
Barely touching the stethoscope, yes. And also without touching.
Away from this.
This you should always remember. Systolic murmurs are graded from 1 to 6. Diastolic murmurs are graded from 1 to 4. 1 to 4. Okay. So that is another very important thing. And the position of the patient. So position, you said that in the left lateral position. Why left lateral position this particular murmur is better heard?
In the left lateral position, the heart will come closer, sir. So we'll be able to hear the murmur better.
Dependent.
The left atrium will come closer.
Yes, left atrium.
Heart. The left atrium.
Left atrium will come.
So that's how. And if there is any radiation of the murmur also, you have to talk about.
Yes, sir.
So this murmur, does it have any radiation?
Yes.
No, sir.
No, sir.
No, sir.
Only mitral regurgitant murmur will radiate to the axilla.
Yes,
Yes, sir.
So that's about details about the murmurs and auscultatory findings. One more is sometimes they can also, you can find Graham steel murmur. What is this Graham steel murmur?
Sir, it's a machinery murmur, sir. We can see in PDA, sir.
No. Graham steel. Graham steel murmur is, the passive murmur because of the pulmonary regurgitation that occurs because of dilated right ventricle. Early diastolic murmur, that is better heard in the pulmonary area. Better heard in the pulmonary area, that is Graham steel murmur. You can also hear a murmur in the left parasternal area. That is in the tricuspid area. That is tricuspid incompetence or regurgitation will be occurring. Because again, dilated ventricle, that produces a functional tricuspid regurgitation and that pansystolic murmur you can hear. So these are some of the murmurs in mitral stenosis. Major murmur is in the apex, that is mid-diastolic murmur with presystolic accentuation. And if there is no atrial fibrillation, and you can have a Graham steel murmur that is in the pulmonary area, that is early diastolic murmur, and a pansystolic murmur all along the left border of the sternum, that is because of functional tricuspid regurgitation. Okay, so now coming to the diagnosis, when you are talking about the diagnosis, because also you have examined the other things. Respiratory system, examination of the respiratory system is very important, especially you will have to look for what?
Look for creps on auscultation.
Yeah, basal creps.
Basal
Basal creps are there, patient may be in
Pulmonary
failure.
failures.
Patient may be in failure. That is one thing again. And also you look for whether there is any tachypnea is there. Accessory muscles of respiration are active, because lung changes occur. With chronic mitral stenosis, there is fibrosis of the lung, because continuously this exudation of fluid from the capillaries into the lung will produce some amount of fibrosis of the lung, and that produces decreased compliance, and the patient will have increased work of breathing, as I was telling you. So that produces use of accessory muscles by the patient. So that is very important, that you should always look for. And one more test you have to do is, the breath holding test for all patients. It will give you what is the reserve capacity for the patient.
Cardiopulmonary reserve.
Yeah, cardiopulmonary reserve. So breath holding you always do for every patient, irrespective of whether the patient has got a respiratory disease, cardiac disease, or any other disease at all. So as long as it is more than 25, you are happy. If it is less than 15 seconds, then you have more problems in managing the patient, isn't it? So that is one more thing you have to add in respiratory system. Okay, then CNS again very important, because there can be thromboembolic problem the patient can have. So don't forget to examine CNS in detail if you have mitral stenosis case. Okay, again, final summary you need not have to write. You can just tell about the provisional diagnosis for the patient. You need not have to summarize the whole thing again, unless you are asked by the examiner. You just tell what is the final diagnosis of the patient. Okay, so what you have written here is probably it's okay. Mitral stenosis of rheumatic origin in atrial fibrillation. When you are writing down atrial fibrillation, whether the rate has been controlled or not, you'll have to write. Well-controlled atrial fibrillation on what drug? Because of what? Is it because of beta blockers? Whether it is because of digoxin? That you have to mention. And whether the patient is in failure or not, cardiac failure, that you have written. Suppose in patient is in cardiac failure, whether it has been optimized or active cardiac failure patient has. So these are the things. And is there any CNS like stroke or any other thing also? You have to mention. Okay. So all these things are fine. Now we'll come to the case management. Of course, we have already spent nearly 3 hours just for discussing the history and examination, which is very, very important. So now coming to actual case management, which is another very most crucial part. These patients can be posted for many things. One is, she's a female patient. We can create a clinical case scenario like this patient is posted for abdominal hysterectomy, elective, or she is posted for laparoscopic total abdominal hysterectomy. You understand? Or she she has become pregnant and she doesn't want pregnancy. She has been posted for MTP. Okay. One more thing is, she has undergone a valve replacement and now posted for MTP. After, say, valve replacement, she has undergone about 1 year back, and now suddenly you are called by, the obstetrician, and you go there. You don't know anything about the patient, and the patient has had a mechanical prosthetic valve, and you are called there, and then you have to provide anesthesia. How you're going to manage? Or the patient has become pregnant. Otherwise, this particular patient has become pregnant, and she had repeated abortions. She requires cervical encirclage. So what is your anesthetic management? Okay. The patient has had a fracture of lower limb. What is your anesthetic? So these are the different, why I'm telling all this is, any other clinical scenario we can create, because, this particular patient has not been admitted for any surgery, isn't it? So since she has not been admitted for any surgery, as an examiner, I can create particular, clinical case scenario and then ask you to discuss about that. Okay, let us say that this patient is posted for abdominal hysterectomy. Understand? Open abdominal hysterectomy.
Okay, sir.
You talk about your anesthetic management. How are you going to investigate? How you are going to prepare this patient? And how you are going to manage this patient?
Investigations, sir. Starting with the investigations. First, I would like to do the general investigations like complete blood count, hemoglobin, to rule out anemia,
Okay.
total count to rule out infection, and also platelet count.
Hemoglobin is only to rule out anemia, is it?
And to have a baseline value, sir.
Just baseline value. What is the importance of knowing about hemoglobin in a surgical patient?
To calculate MABL, sir. Maximum allowable blood loss.
That is very important, isn't it? Maximum allowable blood loss is very important. So you know the formula for that. I will not ask you. Okay, that is very important. One. Second thing is oxygen carrying capacity. Just to calculate the oxygen content, because hemoglobin is the most important factor as far as calculating the oxygen content. So that is why. So the two things you should always tell when you talk about hemoglobin. One is oxygen content, that is oxygen carrying capacity, sometimes we also call it. Second thing is to calculate maximum allowable blood loss. Because we don't know. For example, she has got a huge fibroid. There is always a chance that she may bleed more. And unless you know what is the maximal allowable blood loss for her, then you don't know whether to arrange for blood. If you want to arrange blood, how much you have to arrange for blood. So all those things will be there, isn't it? So that is why that becomes a very important thing. Okay. Then you said total count and differential count. Why total count and differential count?
Rule out any active infections, sir.
Active infection. So what sort of active infection you expect in this patient?
Upper respiratory infections.
Especially streptococcal, isn't it?
Yes, sir.
Streptococcal.
So any active infection, if leukocytosis is there, and it can be actually Jones criteria, minor criteria also. So you will not accept, isn't it? So, okay, leukocytosis and total count, differential count. Right. Then?
Platelet count, sir.
Okay. Platelet count, why platelet count? Usually in this patient, you expect any abnormal platelet count?
No, sir.
You don't expect unless the patient is on heparin.
Heparin, yes, sir.
And HIT is there, heparin-induced thrombocytopenia.
Thrombocytopenia, sir.
You will think. Or otherwise the patient has become pregnant and, HELP syndrome there. Or the patient has fever. Now some of the viral fevers, you can have thrombocytopenia. Isn't it? So all these, especially dengue, if it is there, so then you cannot take up for this elective abdominal hysterectomy. So, okay, platelet count, then?
RFT, blood urea creatinine, sir.
Okay.
To have a baseline value.
Okay.
Serum
So can there be change in renal, function tests in this patient? Can these patients develop renal disease also? Patients with cardiac disease?
Yes, sir. They can develop glomerulonephritis, sir.
Glomerulonephritis is different. That is again as a result of streptococcal infection. What is cardiorenal syndrome? You heard about cardiorenal syndrome? There are 5 types of them. Type 1, 2, 3, 4, and 5, isn't it? So no time to discuss all those things, but patients can have any acute cardiac condition having also can have acute renal problem. That is type 1. Type 2 is chronic cardiac condition, can have chronic renal disease. That is type 2. And type 3 is chronic renal disease, acute renal disease producing acute cardiac condition. Type 4 is chronic renal disease producing chronic cardiac condition. And type 5 is patients having both cardiac and renal disease together. So these are 5 different types of, cardiorenal syndromes. Sometimes you may be asked. So just for that, definitely you will ask about this. Okay. Then
serum electrolytes, sir, particularly potassium values.
Okay.
Because the patient is on digoxin.
Okay.
Random blood sugar.
Right.
And
Blood grouping typing.
Blood grouping typing.
Okay. Okay.
LFT.
Right. All those things routinely you will be doing. Right. But more important investigations. ECG.
ECG.
ECG. So what ECG findings you will be looking for?
irregular, look for features of atrial fibrillation. So
one is atrial fibrillation will be there. Okay. Suppose atrial fibrillation is not there.
P mitral.
P mitral.
P mitral. What is P mitral?
Bifid P waves in lead one, sir. With broad P wave complexes, more than two large boxes.
Broad P waves, yes. Okay.
Yes.
Well, when do you say broad P waves?
More than two large boxes.
More than 2 or 3? It is more than 0.12 seconds. More than 3. More than 3 horizontal, it is widening of the P wave. More than 3 vertical, that is increasing the voltage.
Yes.
Voltage.
So that is P pulmonale. That is very easy. More than 3 horizontally, you say P mitral. More than 3 vertically, you say P pulmonale. Okay, that is right atrial hypertrophy.
Yes.
Right. Okay. Then
right axis deviation.
Right axis deviation.
Right axis deviation can be there, right?
Right ventricular hypertrophy.
Yeah, right ventricular hypertrophy.
Hypertrophy.
Okay, so these are some of the changes you can find in ECG. Right. So right ventricular hypertrophy, how do you know?
It's a dominant R wave in V1 and dominant S wave in V6.
Or RS ratio more than 1 in V1, V2. Right,
Yes,
just
sir.
leads. If RS ratio is more than 1, provided there is no widening of the QRS. Because if there is a widening of the QRS also, then it can be a right ventricular block, RBP. It need not suggest that it is right ventricular hypertrophy. Okay, what are the X-ray findings, radiological findings?
In X-ray, there is a left atrial enlargement will be there, sir.
Okay.
Straightening of left heart border.
It is also called as mitralization of the
left heart border.
Okay. That
And,
is right atrial appendage enlargement.
Yes, sir.
The left atrial appendage enlargement.
Appendage enlargements.
Okay.
Then increase in the cardiothoracic ratio, sir. And double density sign will be seen. Due to
Thoracic ratio, sorry, that may not actually, cardiac size may not increase in right ventricular in a PA view. If there is left ventricular hypertrophy, then there will be, increase in the cardiac shadow. Otherwise, there won't be anything. Okay. Then
double density sign will be there, sir.
Double density of the, what is this double density in the right atrial area? You'll also see a border inside the right atrial border.
Yes, sir. Inside border, yes, sir.
That border is of the left atrium.
Left atrium and yes, sir.
That is shadow in shadow. That's also called as shadow in a shadow. So, and if there is a calcified mitral valve, we can see the calcified.
We can see them, yes, sir.
Isn't it? So those are, and if there is a mechanical prosthetic valve has been there, so that also you can see within the heart shadow. These are the things you can see within the heart shadow. So in the pulmonary shadow, one thing already we said about antler sign, that is inverse ratio, inverse mustache. And what else you can see?
Flaying of carina, sir.
Okay, flaying of the carina, that is because of the enlargement of the left atrium. Okay.
And prominent pulmonary base, sir.
Again, curly B lines, curly A lines, C lines.
Yes, sir.
Curly B lines at the base, curly A lines from the hilar. So laterally they'll be moving. And interlobular lymphatics will give you curly C lines. So these are some of the important radiological findings, because you will have an X-ray of mitral stenosis in the afternoon session. So that will be given to you, and then you will have to comment on these things. So just remember about these. And other very important investigation you would like to go for is echocardiography. The most important thing in any valvular heart disease or congenital heart disease. So what echo findings you would like to look for?
First, look for all the chambers. Then we look for the left atrium to look for any thrombus, rule out thrombus. Then we look for the mitral valve area, sir. Normal mitral valve area will be 4 to 6 centimeters square. Mild will be 1.5 to 2.5. Moderate will be 1.1 to 1.5. Severe will be 0.9 to 1.1, and critical will be less than 0.9, sir.
Usually, anything less than 1, you say it is severe. 1.1 to 1.5 is moderate. 1.6 to 2.5 is mild.
Yes.
So that valve area becomes very, very important to know what is the severity of the mitral disease or mitral valvular stenosis. And second thing is transvalvular
pressure gradient.
gradient.
Mild, moderate, severe again, sir. Less than 5, 5 to 10, and more than 10, sir.
What is the normal transvalvular gradient across the mitral valve? So because you have to know the normal, then only you can talk about the abnormal. It is less than 2 millimeters somewhere.
Less than 2 millimeters.
Less than 2. Because, when the ventricle goes for diastole, it enlarges and relaxes. So it is almost a negative pressure like. It sucks in blood from the left atrium. And because of the gravity from the left atrium, easily the blood will start moving. It doesn't require any pressure gradient. That is why even less than 2 millimeters. But once there is stenosis, the pressure gradient starts increasing. Once it is more than 10 millimeters, it is a severe one. But again, you don't comment on pressure gradient unless, the patient is at rest. Because any slight increase in the heart rate, pressure gradient can increase. Or patient is doing any exertion, the pressure gradient will increase because the flow across the mitral valve will increase, isn't it? So all these things are based on, very important thing is the Garland's formula. You know what is Garland's formula and the application of Garland's formula?
Yes, sir.
Just mention about application of Garland's formula.
Garland's formula is a pressure gradient is equal to cardiac output, the whole square, divided by 44.3 into mitral valve area into heart rate into diastolic filling period. So when the pressure...
Simple way of putting it is the pressure gradient across the mitral valve is equal to actually the flow across the mitral valve whole square. Because you can forget about the area because the area is constant at a particular time. And another is a hydraulic constant, that is a K, 44 point something. So it is a constant. It is actually the square of the flow across the mitral valve. Again, flow across the mitral valve depends on two things. One is the cardiac output. Second thing is the diastolic period. And diastolic period depends on the heart rate. So any decreased diastolic period will increase the gradient.
Yes.
And any increase in the flow across the mitral valve, the cardiac output, that also is going to increase the transvalvular gradient or pressure gradient. So it is very important. So what is the importance of this? Is to see that the heart rate is always kept on the lower. And you don't unnecessarily try to increase the cardiac output intraoperative. Okay, so these are very important things. After these, suppose the patient is also gives you a history that not this particular patient, for investigations. Patient gives history of having a valve replacement done, a prosthetic valve, a mechanical valve replacement. What any extra investigations you will be doing?
PTINR you want to do, sir.
PTINR you have to do, isn't it? So that is a very important investigation. Why you have to do a PTINR?
So because in patient having mechanical valve, we have to maintain the INR of 2 to 3, sir.
He'll be an anticoagulant.
Yes,
he'll be on vitamin K antagonist, isn't it? So that is the reason why you have to get a PTINR done. So that is another very important investigation you have to do. And again, liver function tests, definitely you have to do a baseline liver function test because already we discussed that can be a liver function test because of the back pressure effects. So that also you get it done. So these are the investigations. Okay, you have done these investigations. Now you have to optimize the patient's condition before going in for the goals. Okay, you tell me the goals for this particular patient, anesthetic goals.
We want to maintain the heart rate, sir.
Heart rate, maintenance of heart rate between what?
60 to 80, sir.
So before that, you always tell, avoid, I would like to avoid tachycardia.
Tachycardia.
I would like to avoid severe bradycardia. And I would like to maintain the heart rate between 60 to 80. Why severe bradycardia? Like, for example, the patient has a heart rate of 47, 48. That is anything less than 50 is severe bradycardia.
Yes, sir.
Why severe bradycardia you should avoid?
Because in this case, the stroke volume is fixed, sir. So the heart rate, cardiac output depends on the heart rate only, sir. So bradycardia, cardiac output will be too much reduced.
So cardiac output will come down. Because now the cardiac output is also dependent on the heart rate, isn't it? Because the stroke volume is fixed. So if the heart rate is between 60 to 80, somehow cardiac output will be maintained. But if it is falling below 50, that is a severe bradycardia. So you have to avoid bradycardia, severe bradycardia. You have to avoid, the tachycardia.
Yes, sir.
Maintain heart rate between 60 to 80 because tachycardia is very dangerous.
Yes, sir.
So tachycardia can produce all the problems of increase in left atrial pressure, back pressure effects. So most
Yes, sir.
important thing is to avoid tachycardia. Right, right. That is first goal. What is
Yes,
the
sir.
next?
Maintain the normal sinus rhythm, sir.
Sinus rhythm, if
Yes, sir.
possible.
Yes,
Okay.
sir.
If the atrial fibrillation is there, already there,
We want to control the rate, sir.
control the rate.
Control
Because
the rate.
you cannot bring the patient to sinus rhythm because patient will revert to atrial fibrillation unless you go for a procedure like valve replacement. Afterwards, you can definitely bring the patient to sinus rhythm. So after some time, after valve replacement, whatever the atrial thickening will start coming down. So modulation of the left atrium will occur. And afterwards, you can definitely do a cardioversion. Okay. Then what is the third goal?
Maintain the preload, sir.
Okay. Maintenance of preload is very important. Why preload maintenance is very, very important?
Because if the preload is more, then there is the patient may go to the volume overload status, sir. So patient may go to pulmonary edema if you give a lot of IV fluids. So there will be a judicious maintenance of IV fluids intraoperatively, sir.
Okay. One is you should not increase the preload. Okay. Why you should not decrease the preload? Why you have to maintain the preload? What happens if there is a decrease in preload?
If the decrease in preload will be there, then the cardiac output also will be reduces, sir.
Because cardiac output, stroke volume is again preload dependent.
Yes, sir.
These patients. So that is why you have to maintain the preload. You cannot have a decreased preload. You cannot have an increased preload. It is like walking on a tightrope and balancing everything. A very difficult case, especially if it is severe mitral stenosis. Okay, that is the third goal. What is the fourth?
Maintain the systemic vascular resistance, sir.
Okay.
And
what happens if you increase the systemic vascular resistance?
If SVR is more, then the cardiac content, like workload will be more, sir. So the heart has to pump against the more pressure. So there is increased demand of oxygen and more requirement of.
Don't worry. Don't think about coronary artery disease. This is not a coronary artery disease. This is a mitral stenosis. What has happened to the left ventricle?
Left ventricle is failing, sir. So
failing. It is not failing. Left ventricle is in 70% of the patients, it is normal. But it may be, it is not getting enough volume. If it is not getting enough volume, so it is not able to pump well. And if there is increase in afterload also, the amount of stroke volume will further come down.
Yes, sir.
Stroke will suffer. That is why you should not increase the afterload, but slight decrease in the afterload is still okay. So that the cardiac output can increase. Slight decrease, not sudden decrease of or more decrease of the systemic vascular resistance. You should avoid that, isn't it? So that is what, in case of spinal anesthesia, a sudden abrupt decrease in
systemic vascular resistance.
Okay. So, okay, fine. Then
one more. Reduces the pulmonary vascular resistance, sir.
Pulmonary vascular resistance should not be increased. Okay.
Yes, sir.
That is very important. Already there is an increase in pulmonary vascular resistance. What are the factors which will increase the pulmonary vascular resistance?
Sir, hypoxia.
Hypoxia.
Hypoxemia,
hypercarbia,
acidosis, hypothermia, sir.
Yeah, these are the conditions which can increase the pulmonary vascular resistance. Already there is a rise pulmonary vascular resistance. So you should avoid these things, isn't it? So avoid hypoxia, hypercarbia, acidosis, and hypothermia. Very good. So one more. What about myocardial contractility?
Maintain adequate contractility.
Yeah, myocardial contractility, because already there is a probably decreased contractility is there. Don't suppress further. So maintain the myocardial contractility. Okay, with these goals, now for this patient with probably has, I'll give you, after the investigations, you have found out that she has 1.2 square centimeters of mitral valve area and posted for open abdominal hysterectomy. What is your anesthetic technique of choice?
The plan of anesthesia is general anesthesia with epidural, sir.
Okay. So, but otherwise, for example, now this was a patient who has got a normal heart, posted for abdominal hysterectomy. What would have been your anesthesia technique?
Sir, combined spinal epidural.
Combined spinal epidural, or even spinal you would have given.
Spinal, sir.
So why do you want to avoid spinal in this patient? Based on
if you use spinal, there is a sudden sympathetic block and a sudden fall in SVR, sir. So the cardiac output will be reduced suddenly, sir. Patient may collapse.
Hypotension occur. Severe refractory hypotension, you may not be able to manage, and the patient may go for cardiac arrest. So that is the reason, and you want a very high block, isn't it? T6, T4 block, abdominal section, because the peritoneum is being handled. So that is why it is better you should avoid spinal. Okay. So how about graded epidural? This is a moderate severe. This is not severe. 1.2 square centimeters. That's why as examiners will give you what is the area.
So we can go with the graded epidural, sir.
That is one thing you should always, if it is a mild to moderate mitral stenosis, still graded epidural is one of the choice. You can always go for, because there are a lot of advantages of graded epidural and avoiding GA in this patient, isn't it? GA itself, you can produce multiple problems, like even, laryngoscopy itself can go so high, and you will end up with a patient having a pulmonary edema, and you'll be managing the pulmonary edema, and the surgeon cannot progress, isn't it? So that is how you should try to avoid if possible. So graded epidural. So now, Shruti, how do you go for graded epidural? Where do you want to place the epidural catheter?
I'll place the epidural catheter at T12 at once.
Mukhtar, are you there, Mukhtar? Mukhtar is there or not? No,
Yes, sir.
No, I just wanted to ask you, can we extend for about 15 minutes more? 7:15?
Yes, sir. We can. Problem, sir.
There is no problem as far as your Zoom timings are concerned.
No, nothing.
Okay. So I want to actually today finish only. That is the reason. So if you people are okay, then Okay. Now graded epidural, Shruti, tell me how we are going. Where exactly? What is the point at which you place the?
I'll place the epidural at T12 L1, sir.
T12 L1. Okay.
L1,
Okay. Fine. Okay. Slightly higher lumbar or lower thoracic.
Yes.
Why did you select T12 L1 in a particular reason?
Because there'll also be peritoneal stretching, so she should not feel any pain during tracking.
Is it easy at T12 L1 to give our T11 12?
No, sir.
Are almost horizontal.
Yes, sir.
Becomes easy actually than epidural catheter. Okay. So you want to place the epidural catheter there. Fine. So how do you grade the epidural? First, you have to know whether your epidural catheter is properly placed or not, isn't it?
Yes, sir.
How do you know your epidural catheter is properly placed or not?
Sir, epidural space is a negative space, sir. We can check anchoring of test and inverse meniscus sign, sir.
Pardon? Hello,
sir. Is hearing?
I'm able to hear, but my image has gone somewhere. Yeah. So can I rejoin once more?
Yes, sir.
Just 2 minutes, I'll just rejoin.
Okay, sir.
Okay. I'll just rejoin. Graded epidural. Test dose, isn't it?
Yes, sir. Test dose. Give 2% lignoadrenaline, 3 ml.
So something, that's the reason why I'm asking you. Will you give adrenaline as?
No, sir. Not here, only plain lignocaine, sir. 2% lidocaine.
Okay, Kaushik, why not adrenaline?
Sir, because adrenaline increases the heart rate, sir.
No, but the amount of adrenaline what you are using is only about a very small amount, isn't it? 15 micrograms of adrenaline you will be injecting in 3 ml of lidocaine with adrenaline, 1 in 2 lakhs adrenaline. So it's only 15 micrograms. Every ml will contain 5 micrograms.
Yes, sir.
So do you think that it will produce increase in heart rate normally?
Yes, sir. It will produce increase in heart rate, sir.
No, it will not increase the heart rate. But if your catheter is intravascular,
it will increase.
Then it will increase.
Yes, sir.
You don't know. Your catheter may be in the intravascular space, isn't it? So
yes,
that is what you are trying to test, whether it is intravascular or intrathecal. That is
Yes,
what
sir.
a test dose. So better to avoid adrenaline as a test dose. Definitely. And you always think that your catheter may be intravascular. Otherwise, you can just check by using, about 50 micrograms of or 100 micrograms of fentanyl and see how the patient will behave, whether she is having some sedation. If it is there intravascular, it will produce some amount of sedation, or a small 1 drop or 2-3 drops of air you can rapidly push with a precardial Doppler if it is available. Otherwise, better avoid adrenaline. So lidocaine you can still give, and you can do the testing. So test dose becomes very important. And afterwards, 3 ml you have already given. Afterwards, what drug you will be using? Lidocaine with adrenaline, lidocaine plain will be using, or bupivacaine you will be using?
Bupivacaine we use, sir.
Bupivacaine, what percentage?
Sir, for anesthesia, 0.5% bupivacaine we use, sir.
Yeah, 0.5% bupivacaine for anesthesia. Very good. So how do you grade it now?
Every lumbar segment will be 1 centimeter, sir. 1
How do you grade? That means you will be giving very slowly, isn't it?
Yes,
that means you are giving in increments. Slowly means in increments of the bupivacaine, 0.5%. So what increments you will be giving?
Increments of 3 ml, sir.
Yeah, usually you go for 3 to 5 ml increments and wait for 5 minutes in between the increments. Check the level of the block and then only you continue. So that is what. And usually for a patient who is 150 centimeters, if you are placing in the lumbar level, usually your requirement is about 1 ml per segment.
Yes, sir.
Yes.
1 ml per segment. And you have to block about 15 or 16 segments in this patient. So totally you may require about 15 or 16. Roughly you may have to go for 5 ml increments. So you take about 15 minutes to give this 15 ml. So that is what is called as a graded epidural. So, but what is one problem with this only epidural is the sacral fibers, they will not be blocked.
Yes, sir.
Because your epidural catheter you are placing at T12L1 and you're pushing it another 3 to 5 centimeters. Somewhere it will be at T8 level. So where about the sacral fibers are very thick fibers and they are quite away. So how do you manage it's a pelvic surgery.
Yes, sir.
Sacral fiber, the patient will become a lot of discomfort will be there for the patient. Once the patient has discomfort, the heart rate will increase and you will have a lot of problems. How do you manage?
We'll manage with systemic opiates, sir.
No, ideal would be you can go for another 2 techniques are there. One is low dose spinal with epidural, otherwise called a sequential combined spinal epidural. You give just 1 ml of spinal and followed it by epidural grading. Many times 1 ml of spinal when you give and make the patient in lying down posture afterwards, supine posture, usually it will not go beyond T10. It will be below T10, but a dense sacral block will be there. It will not produce much of sympathetic block. Anyway, afterwards you can grade up with epidural. That is one of the most commonly used nowadays for cardiac patients posted for below umbilical surgeries, where sacral fibers also have to be involved. So you go for a combined spinal epidural. It is called as a sequential combined spinal epidural, otherwise called as low dose spinal with a graded epidural. Low dose spinal with graded epidural. So that is one thing. Or you can go for dural puncture epidural. You have heard about dural puncture epidural?
Yes, sir.
Puncture the dura with a 27 or 28 gauge needle, and then you don't inject anything. Now place an epidural catheter and then follow it up with a graded epidural. Now, because you have created a small hole in the dura, some amount of the drug will enter into the intrathecal space, and it also will be producing good sacral analgesia. So these are the things which you can modify your technique of neuraxial technique. Okay. So, but there are, this can be your thing and you can manage intraoperatively also. We'll come to that. The other anesthetic technique, Kaushik was mentioning about GA for this patient. GA with epidural analgesia. That is what you mentioned, Kaushik.
Yes, sir.
Okay, so when do you want to go for a GA in this patient?
When the patient has severe.
Yeah, very good. So But when the patient has got severe mitral stenosis, would you prepare the patient before, or would you? It's an elective procedure.
Yes, sir.
You directly go for, okay, let me go for anesthesia itself.
No, sir. We want to, if the valve area is less than 1 centimeter severe, we'll do the percutaneous balloon metal commissurotomy, sir, and we'll increase the valve area.
You will
1.5
have a
centimeter.
discussion with the gynecologist, and also you'll have a discussion with the cardiologist together. It's always a team effort, isn't it? So you can always discuss the cardiologist to go for the patient to undergo a percutaneous balloon mitral commissurotomy, provided the mitral valve is a pliable mitral valve. So you go with Wilkins score. You will, because lack of time, I'll not go into details about this Wilkins score. You look for the valve, mobility of the valve, calcification of the valve. So if they are convenient, then one can go for a balloon mitral commissurotomy. That is important. Otherwise, suppose if the valve is severe mitral stenosis and the patient is not for that means the valve is not congenial for balloon mitral commissurotomy, then what the next option for you?
Mitral valve reconstruction.
Definitely this patient will require a mitral valve repair or replacement anytime. So definitely you can request for going in anyway, because afterwards also she is going to require. And abdominal hysterectomy may be an elective procedure. You can definitely postpone. So, thinking about all these things, you can consulting with the cardiologist and the cardiac surgeon. So this patient can undergo a valve replacement, and afterwards, after say 3 months or 4 months later, you can take the patient for abdominal hysterectomy. So these are the things which you can always think about. And suppose you plan for GA only in this patient. Okay. So how do you go ahead and then give GA for this patient?
Starting from the previous day, sir.
Yeah, previous day, fine.
Previous day, we'll explain the nil per oral status. We'll assess the patient. We'll get a written informed consent. And then we'll ask the patients to continue or discontinue the cardiac medications.
Okay. Already we have discussed those things.
Yes, sir. Yes,
right.
Sir. On the day of surgery, I'll give medications, sir.
No, another very important thing is the anxiolysis.
3 medications, sir.
Yeah, anxiolysis on the previous day, or when the patient has been told that she requires surgery, you will have to give anxiolysis for the patient, isn't it? Both psychological anxiolysis and pharmacological anxiolysis, both are very important.
Yes.
So when you are giving an anxiolytic drugs, what are the things which you will be keeping in your mind for this patient? So you have to avoid hypoxia and hypercarbia. And for example, you give an anxiolytic which produces depression of the respiratory center. In the night, the patient will develop hypoxia and hypercarbia, and in the morning, she'll end up with a pulmonary edema, and you'll not be able to accept. So that is why you'll have to go more of a psychological anxiolysis rather than pharmacological anxiolysis. With a minimal pharmacological anxiolysis and more of psychological anxiolysis, so that you know that the patient should not develop any hypoxia or hypercarbia, and her heart rate is also on the lower side. Her anxiety levels are quite low. So that is what you will have to maintain. Okay. All these things. Yeah.
Anti-aspiration prophylaxis also, sir.
Anti-aspiration prophylaxis. That is entirely.
Pantoprazole.
No, either you say anti-aspiration drugs
anti-aspiration drugs.
Prophylaxis or preventive.
Okay, sir.
Isn't it? Aspiration prophylaxis. Don't say anti-aspiration prophylaxis.
Okay.
So why aspiration prophylaxis? You think that this patient is prone for aspiration? Should it be a routine thing?
Yes, sir.
Yes,
routine thing, sir.
Yes, sir.
Yes, routine thing.
Because you are taking it as an elective procedure, you are allowing her to drink clear fluids till 2 hours before. And you should not go for, unless it is an elective procedure, or if she is a pregnant patient or obese patient, isn't it? Such patients only are prone for, or diabetic patient with autonomic neuropathy. So such are the patients whom you think that they are full stomach, and you should go for aspiration prophylaxis. But routinely, you need not have to give. Okay. Because any extra drug can produce problems in these patients. You don't want to have that, right?
On the morning of surgery,
Okay.
I'll reassess the patient again. I'll do the machine check, load emergency drugs, and I'll get the appropriate airway cart ready. I'll secure an 18 gauge Venflon in the left upper limb. And
How do you secure?
by giving lignocaine locals to prevent pain.
Lignocaine will also produce pain. You inject a transdermal injection of lidocaine with say 26 gauge needle, and that stings. And the patient may have sudden increase in heart rate. Better than that is Emla cream.
Emla cream, sir.
Yeah, you identify the vein where you have to mark the vein so that the sister or the ward staff should not puncture it. And over that 1 hour before you apply Emla cream, and that should be ideal thing. If you have applied Emla cream and then unnecessarily you have a double puncture, then definitely you can go for a local injection of lidocaine. Then only. Otherwise, try to reduce the pain. Maybe these are, even though they are minor things, they are very, very important for this patient. This patient is not an ordinary patient. Okay. So you have used the Emla cream. You got a 18 gauge or 20 gauge. Which one you want to use?
18 gauge.
18 gauge, because abdominal hysterectomy, the fibroid uterus is there. So it's better to have an 18 gauge needle, right? Okay. Okay, then
I'll shift the patient inside.
No, you don't want to start some fluids. You just want to have an IV line.
We usually start it inside.
Okay, you don't know whether it is flowing or not.
We'll connect ringer lactate.
You can definitely make it connect some IV fluid and let it go very slowly. It will keep your vein patent also, because otherwise, by the time you take her inside, the patency may not have there may be thrombus formation. So always start some slow IV fluid. Okay, you have started that also, then right. And you have taken the patient inside the
OT, sir.
You have to connect some monitors.
Yes.
What monitors will be connecting for the patient?
Standard ASA monitors, sir. Pulse oximeter, ECG, and a non-invasive blood pressure monitoring, sir.
Okay. Okay.
And
which lead?
Sir?
You have a 5-lead ECG, isn't it? So
yes, sir.
Which lead do you want to select?
Sir, lead 2, V4. Sir.
Lead 2 and V5 usually.
Lead 2, V5. Okay.
Lead 2 for what?
Sir,
rhythm disturbance.
Rhythm stick.
V5 for?
Sir, V5 is for
ischemia. Though
ischemia,
you may not expect ischemia, but usually that is what? Lead 2 and V5 is routinely you select. Okay. NIBP and this, and what else?
Foley's.
Pardon?
Sir, urinary catheterization, sir, for urine output.
No, that they were going to put. This is for abdominal hysterectomy.
Okay, sir.
So usually they are going to place it later also, sometimes, or continuously they may be placing. Don't worry about it. Okay. Okay.
Sir, then I will start pre-oxygenating the patient, sir.
You don't want any ETCO2 monitoring?
Sir, that after.
No, during pre-oxygenation.
Yes, sir. Okay, sir.
Isn't it? So you always connect it to the mask itself.
Yes, sir.
So anyway, that elbow is there. So to that
yes, sir.
provision is there, and you have to have a baseline ETCO2 also before holding. So invasive monitoring for this patient. Do you want invasive monitoring or you don't want any invasive monitoring?
So we don't want invasive because it's a moderate.
Moderate. Suppose definitely, invasive monitoring depends on what?
Sir, if it is severe mitral stenosis.
One is severe disease, another is magnitude of surgery.
Yes, sir.
Just remember these two sentences. If you are asked in the exam, about the invasive monitoring for any patient. One is the severity of the disease. Second thing is the magnitude of surgery. Suppose the patient's disease is very severe, like this patient has got a severe mitral stenosis and bleeding also through the vaginal bleeding is there because of the problem with the uterus. So they want to take up as early as possible. So then actually people have done valve replacement and abdominal hysterectomy together.
Yes, sir.
That has been done. But suppose there are not much of a provision for the patient to undergo the valve replacement, you may have to take up for the abdominal hysterectomy only straight away. In such situations, unlikely situations, then definitely the severity of the disease is so much, then you have to go for invasive monitoring. Plus, suppose the patient is taken for a major surgery where there is a lot of fluid shifts and also you expect a lot of blood loss. Then also you will go for
Invasive monitoring, sir.
That is what you have to think about two things, magnitude of surgery and severity of the disease. That is what you tell in the exam. Okay. So another very important thing here, she may require an arterial line. Why you want her to have an arterial line in this patient with even moderate mitral stenosis?
Sir, arterial you can monitor the blood pressure, beat to beat blood pressure you can monitor, sir.
Yeah, continuous. It is a continuous blood pressure monitoring. More accurate.
Frequent ABGs, sir. Because if there's a lot of blood loss.
Sir, and
Okay, if you are planning for repeat ABG, suppose the patient also has got severe lung problem because you wanted to avoid acidosis.
yes, sir.
No, because one thing you should always realize, the fluid management.
Yes, sir. Pulse pressure variability and
disease, you can have a flow track monitor and you can know about stroke volume variation, pulse pressure variation,
variability,
systolic pressure variation. So all these you can definitely continuously monitoring these variations. If the variations are more than 13%, the patient will be requiring a fluid bolus.
fluid bolus.
Slowly you can give about 150 ml of fluid bolus and see the variations. And you can keep giving these boluses very slowly over 10 minutes until the variations come down below 10%.
Yes, sir.
Then you know that the fluid, the whatever the fluids you are giving is you are giving an optimized fluid. That is based on your Frank-Starling curve, because you have to know where your patient is in the Frank-Starling curve. He is in the flatter part of the Frank-Starling curve or in the steeper portion of Frank-Starling. As long as the fluid responsiveness is there, that is more than 13% of stroke volume variations are there, then the patient is in the steeper part. That means the patient still requires fluid and fluid responsive. So because, any excess fluid, very dangerous. Already we have discussed. Any fluid, hypovolemia is, these patients cannot tolerate. So that is why in these patients, you can always tell, you can have a arterial line, you can use a flow track monitor if you have, and that will be very ideal for these patients with severe mitral valvular heart disease. Okay, so that again you can think about this. Even if you are well versed with transesophageal echocardiography, definitely you can use transesophageal Doppler. So all these you can use for fluid responsiveness. Okay, just remember about that. You can write in the theory about all these things. Even in the exam, if the examiner asks, you should be able to talk about these things. How you manage the fluid, intraoperative fluid management. Okay, right. These are the, and if you have a nerve stimulator, peripheral nerve stimulator for neuromuscular junction, definitely you can have a neuromuscular junction monitoring as well, because you don't want any residual neuromuscular palsy for this patient. Very important. Post-operatively, if she develops residual neuromuscular palsy, she's going to have hypercarbia, hypoxia, acidosis, all whatever the Herculean effort you have made during your intraoperative period will go waste, isn't it? So very important again, neuromuscular junction monitoring. If you can have, or you have that facility in your hospital. Okay, so these are the monitoring. You have already started with these monitoring. Then let us know how you are going to proceed with.
Sir, I will start pre-oxygenating the patient, sir,
Okay.
with 100% O2 for 3 minutes.
Okay. This
Then,
patient requires a shorter time or a longer time for pre-oxygenation?
sir,
This patient with decreased lung compliance, decreased FRC probably requires
Yes,
a
sir.
shorter time or a
Longer
longer
time.
Huh?
longer time. We want to increase
No.
the pre-oxygenation time, sir.
No, if the patient has got a small FRC, easy to fill early. Time constant for filling this smaller FRC will become, shorter, isn't it? So you can definitely, but what is the end point if provided you have a very good workstation where you can even measure the entire concentration of oxygen?
More than
More than
90%, sir.
Yeah, ETO2 should be more than 90%.
90%, sir.
That will be your endpoint for
Pre-oxygenation.
pre-oxygenation. Right. You have done the pre-oxygenation. Fine.
Then I
Okay.
will. Then I will give.
In the meantime, are you not giving pre-medications?
Yes, sir. I will give injection midazolam 1 mg IV, sir.
Okay.
And for pain, I will give injection fentanyl. The weight of the patient is 50 kg, sir.
Okay.
So I will give injection fentanyl 100 mg IV.
100 micrograms.
100 micrograms IV.
Okay.
Then once the patient is and I wait for 2 to 3 minutes, then I will start induce the patient, sir. I will induce the
So
patient.
only these two are enough. What is the most important thing in these patients? As far as, you want to go for endotracheal anesthesia or supraglottic airway anesthesia?
Sir,
endotracheal.
okay.
Let us say that your gynecologist is very fast, so she can do in just about half an hour or 45 minutes. Which one you would like to go for? Supraglottic airway second generation or endotracheal?
Supraglottic, sir.
Why? What is the advantage of supraglottic airway?
In supraglottic, we are not manipulating the airway, sir. So there is no laryngospasm or bronchospasm.
Nothing to do with laryngospasm can occur even
sir.
in supraglottic airway.
Rest response would be reduced.
That is what, intubation response, laryngoscopic response you want to avoid.
Yes, sir.
And if you can have a Procil LMA or Supreme LMA or Basca mask or any of these second generation LMA, definitely they can be used in this patient.
Yes, sir.
Provided it all depends on the surgeon and the duration of surgery. Isn't it? If it is exceeding more than 1.5 hours, better to intubate this patient.
Yes, sir.
And another thing, why probably sometimes you may think intubation may be better because you may be expecting this patient to develop pulmonary edema intraoperatively. That is one of the complications you are expecting, though you are trying to avoid it, but you don't know. Sometimes it can occur because suddenly the patient becomes light, heart rate increases, you end up with pulmonary edema, the patient. If you have a supraglottic airway device, you can manage better, or if you have got an endotracheal tube, you can manage better.
Endotracheal tube we can manage better, sir. We can post-op ventilate the patient.
So that way, in the exam, you may be asked all these things. Why I am asking you now only? Because I am trying to prepare you for the exam. So you may be asked. So you may tell, I would like to go for a supraglottic airway device in this patient because the surgeon, I'm thinking of surgeon is going to finish fast. And I want to reduce the response as far as the airway is concerned, securing an airway is concerned. Okay, so you want to go for endotracheal intubation, let us say, right?
Yes, sir.
So you have to suppress the intubation response. What additional drugs you would like to use?
Sir, for suppress intubation response, can give IV Loxicard, sir.
No, don't tell about Loxicard. It's a name.
Preservative-free
lignocaine.
That you have to give because what is the induction agent you will be using?
Sir, etomidate, sir.
Even etomidate produces pain on injection. Just remember, both propofol and etomidate produces pain on injection. So you will have to use lidocaine first. Other than these, any drug which can reduce the heart rate?
Small we can use, sir.
No, dexmedetomidine.
Yes, sir. Dexmedetomidine.
Yeah, but you have to be extremely careful. You have to give lower dose. Not usually you go for 1 mic per kg.
Yes, sir.
Over
10
minutes.
10 minutes.
So you can reduce it to 0.5 mic per kg body weight, and you may take slightly longer, about 15 minutes,
sir.
because you don't want hypotension, because it also reduces the systemic vascular resistance. So, but it's a very good agent as far as the reduction in the heart rate and also deepening the plane of anesthesia. It also produces analgesia. It won't produce respiratory depression. So multiple advantages are there with an alpha-2 agonist like dexmedetomidine. Definitely you can use dexmedetomidine. It is going to help you in suppressing the intubation response. Okay, one more thing is, just before you intubate, you also give 0.5 milligram per kg body weight of esmolol.
Yes, sir.
That is another very important thing in patients with MS or aortic stenosis. Very important. And what are the important things you will be doing when you are doing an laryngoscopy and intubation, which can suppress or reduce the intubation response?
So we can spray the 10% lignocaine spray.
Never spray. Spraying will produce more problems. It can even induce laryngospasm. So one thing is short duration of laryngoscopy, gentle laryngoscopy. If you apply more pressure, more response. Shorter duration, less than 15 seconds, and maintain adequate depth of anesthesia. These three things are very, very crucial. Okay, before actually. Plus, you have used dexmedetomidine. Also, you have used lidocaine, 1 to 1.5 milligram per kg body weight. You have used fentanyl. You have used midazolam. All these things are going to help, isn't it? Plus esmolol. So all these, very important to suppress intubation response, because before actually you start the surgery, patient will be in pulmonary edema. So very important, you have to look after. Okay, somehow you have intubated using all these things, because here the pressure response is not so important. It is actually the heart rate response. That is more important in a patient with mitral stenosis. Whereas in a patient with ischemic heart disease or a patient with hypertension, then preeclampsia, all these patients, even pressure response, you have to. So pressure response means blood pressure response. Okay. So you have intubated the patient. Okay. Next what?
Maintenance of anesthesia, sir.
Yeah, okay. Maintenance of anesthesia.
I'll maintain with oxygen, air, and sevoflurane. So I'll avoid nitrous oxide.
You want to avoid nitrous oxide. So what are the reasons? Why do you want to avoid nitrous oxide?
Because there's a possibility of increase in peripheral pulmonary vascular resistance, sir.
Okay, that is one thing, and that is the most important thing, isn't it? And also it can produce myocardial depression.
Yes,
Right? So because of these two things, you can avoid. But the problem is, if you avoid nitrous oxide, patient can be in the lighter planes. Nitrous oxide always will help in maintaining the depth of anesthesia. Why? Because it itself is an inhalation anesthetic agent, isn't it? So if you are avoiding, then you have to go for a higher dose of inhalation anesthetic. So higher dose of inhalation anesthetic agent will produce any problems for this patient?
Myocardial depression will cause, sir.
Myocardial depression and vasodilation also. So that you have to be careful about. So you may have to continue with your dexmedetomidine, low dose dexmedetomidine continuously, along with your sevoflurane also, isn't it? So that's how you can definitely maintain, or you can also use some amount of extra amount of opiates intraoperatively.
Yes, sir.
You have remifentanil, you can start using remifentanil. You are using remifentanil in your hospital?
No, sir. We are using fentanyl only.
Pardon?
No, sir.
No, sir. We are not using.
No, it has been introduced in India, isn't it? So it's a fantastic drug. So because, you can go for continuous infusion of say 0.025 micrograms per kg per minute of remifentanil. So as long as you want good depth of anesthesia, you can continue. And it is absolutely cardiostable. So if you don't have remifentanil, you can give repeat doses of fentanyl also. 2-3 repeat doses to maintain the depth, because you can't rely on depth of anesthesia using only inhalation anesthetic agents, because they have their own problems on myocardial contractility. Okay, that is another thing. So how do you maintain the ventilation? What is the tidal volume you're going to select for this patient?
6 to 8 ml per kg body weight.
Usually around 8 ml per kg body weight. And respiratory rate, based on
ETCO2, sir.
ETCO2, sir.
respiratory rate based on ETCO2. ETCO2 maintained between 35 to 40 millimeters.
40.
Okay. What are the intraoperative complications you expect?
Patient may develop pulmonary edema, sir, volume status.
Now, what are more common than pulmonary edema straight away? More common. So, patient can develop tachycardia.
Yes, sir.
Patient can develop bradycardia because patient is on digoxin, isn't it? I did not ask what you are going to give for intubation.
Sir?
Muscle relaxant for intubation.
Sir, Vecuronium, sir.
So, you want to avoid succinylcholine.
Yes, sir, succinylcholine, sir.
Okay, okay. Because, patient is on digoxin. And,
Profound effect of digoxin, sir.
there can be severe bradycardia.
Bradycardia will be there, sir.
Okay. So, intraoperatively, the patient can go for bradycardia, can go for tachycardia. If the patient goes for tachycardia, how do you manage?
Sir, we'll use metoprolol, sir.
Metoprolol or esmolol?
Yes, sir.
Esmolol also, sir.
Because, metoprolol, once you give, you cannot withdraw.
Yes.
And it is a longer acting drug when compared to esmolol.
Esmolol, yes.
So, you can have a continuous infusion with a syringe pump. Esmolol, say 100 micrograms per kg per minute esmolol. You can titrate based on the heart rate, isn't it?
Sir.
What is the cause for increase in the heart rate?
Pain, sir.
So, majority light play.
Pain,
So,
yes,
it's
sir.
not just correcting the heart rate with esmolol, you have to increase the depth of anesthesia, isn't it? So, such patients, if you can have a BIS monitor, fantastic. You can
Yes,
also
sir.
know exactly you can control the depth also. Special patients. Okay. So, tachycardia, bradycardia, how do you manage?
So, bradycardia, we can give atropine, sir.
So, atropine, again, you cannot straight away give 0.6 or 1.2 milligrams. You have to go
Yes, sir.
gradually. Increment.
Gradual.
Because
Right.
that may produce tachycardia, which is dangerous, isn't it? So, that is another problem. So, hypotension is another problem. So, how do you manage hypotension intraoperatively?
We'll use phenylephrine, sir.
Phenylephrine. But if the patient also has got pulmonary hypertension, what is the effect of alpha agonist, pure alpha agonist phenylephrine on the pulmonary arterial pressures?
Increase
It will
the
increase
pulmonary
the pulmonary pressure.
Can produce, isn't it? So that you have to keep it in mind. So if you have vasopressin, many times vasopressin may be an ideal choice in such patients, because vasopressin, it produces increase in systemic vascular resistance, but doesn't have any effect on the pulmonary vascular resistance. For theory, you can always write down these things, but sometimes you may be asked in the practicals also. Then you can go for 0.04 units per minute of vasopressin also. Okay, so otherwise phenylephrine is good because it doesn't increase the heart rate. Okay, so suddenly if the patient develops pulmonary edema, how do you manage?
give 100% O2, sir.
Okay. How oxygen will help? 100% oxygen in patients who have developed pulmonary edema. How it can help?
It will cause
Bronchodilation, sir.
Bronchodilation. No, oxygen has nothing to do with the bronchial smooth muscle. It produces some dilatation. What dilatation? What is the effect of hypoxia on pulmonary vascular resistance?
it will increase hypoxia.
What is the effect of hyperoxia?
Yes, sir.
Yes, sir.
It dilates, it
Yes.
decreases. And pulmonary edema is due to, that is the back pressure effect. Already we have discussed, isn't it? What may be the cause for pulmonary edema in this patient? Sudden increase in the hydrostatic pressure. You have to decrease the hydrostatic pressure. So when you give hyperoxia, when you produce, that is going to produce vasodilatation of the pulmonary vessels. Very important. That is how, 100% oxygen help. Plus, these patients may be going in for hypoxia because, fluid entering into the alveoli is preventing the oxygen exchange, isn't it? So, two advantages. Okay, one is 100% oxygen. Then
Positive pressure ventilation, sir.
that already you are doing.
But
Already
giving,
doing
sir.
it. And then
Anything
injection
extra you
morphine.
need?
Diuretic, sir.
Doing a positive pressure ventilation, you are doing with PEEP of say 5 centimeters. You're not going to go higher than 5 centimeters for majority of the patients, isn't it? Now, when the patient has developed pulmonary edema, do you want to increase PEEP or not?
Yes, sir. We want to increase PEEP.
You have to increase PEEP.
Increase the PEEP.
And go up to 8 to 10 centimeters of water of PEEP, because that is going to further intrathoracic pressure will increase, decrease the venous return, and decreases the pulmonary congestion, isn't it? Plus, there is theoretical possibility of pushing back the fluid from the alveoli back into the capillaries. There's a theoretical possibility because you are increasing the alveolar pressures by using PEEP. So definitely mechanical ventilation, already the patient is on. So immediately you increase the PEEP. In the meantime, what else you are doing?
Sir, you diabetic, sir.
Head and elevation.
Head and elevation. Yes.
All those things continuously, they are, 100% oxygen, head and elevation, increase PEEP. Okay. And deepening the plane of anesthesia, because everything probably because of lighter plane. You have to deepen the plane of anesthesia. And then you can give diuretics also, furosemide. So that's how you can go for managing, because this is another common complication that can occur in these patients. You should be prepared for it. Okay. Another complication is, patient may not be in atrial fibrillation, can develop intraoperative atrial fibrillation. How do you manage? Intraoperative atrial fibrillation.
Sir, we want to try to control the rates, sir, first.
No, again, just see if the patient is stable or unstable.
Yes, sir.
If the patient is stable, you go for rate control.
Air control, sir.
If the patient is unstable, go for
Synchronizing cardiovascular, sir.
cardiovascular. So that is what your answer should be. If the patient is stable, go for rate control by giving beta blockers. Esmolol is there, or metoprolol you can give 5 milligrams of metoprolol. So if the patient is unstable, definitely you should go for
Synchronizing cardiovascular.
So immediate cardio. So you should keep your defibrillator ready in all these patients, because they are highly, arrhythmogenic patients. Okay, so somehow you have managed. How do you extubate this patient?
Before extubation, we use respiratory lidocaine, sir, to reduce the pressure.
Again, you have to look for extubation response, which can be more dangerous than intubation response, isn't it? So you have to see that patient is completely come out of the neuromuscular blockade, and in 1 hour you can use to see that the extubation response can be decreased. What is Bailey's maneuver? Bailey's maneuver. In all these such patients, you can use Bailey's maneuver. What you can do is, before reversal or after reversal of the patient, but keeping the patient very deep with the IV or inhalation anesthesia, you introduce a supraglottic airway device behind the endotracheal tube and take out the endotracheal tube. Inflate the supraglottic airway cuff, if you are using a cuffed, inflatable cuffed supraglottic airway, and then take out the endotracheal tube. Because patient is deep, when you take out the endotracheal tube, there won't be any response. Allow the patient to now reverse the patient, allow the patient to gradually come out of, and you cut off all the inhalation anesthetic agents and all. So patient will gradually come out and pulls out the supraglottic airway device. This is called as Bailey's maneuver. And there are 2 contraindications for Bailey's maneuver. One is the patient is full stomach, you don't go for it. Second thing is patient has an extremely difficult airway, you don't go for Bailey's maneuver. So with this, suppose if these patients also have these kind of contraindications, then definitely you may have to give again a dose of esmolol or a dose of lidocaine or additional dose of fentanyl or additional small 20 or 30 milligrams of propofol just before you extubate. All these will prevent respiration. Okay, so post-operatively, good analgesia is very, very important. You have you have an epidural. You can activate the epidural just before you extubate, isn't it? So epidural analgesia will definitely help. And low dose epidural, low concentration of the local anesthetics will not produce so much of sympathetic blockade to produce any problems.
Yes, sir.
Okay, so that's about your GA for this patient. So you have time for other type of, I told about patient posted for with a mechanical valve,
Yes, sir.
Yes.
posted for any kind of surgery. So how do you manage? You know that patient gives a history of mechanical prosthetic valve. Or sometimes in the theory, you will have patient who has undergone a valve replacement for mitral stenosis, posted for abdominal hysterectomy. Your anesthetic management. So what you should assume in these patients with mechanical prosthetic valve?
They'll be on anticoagulant therapy.
That is what you should assume. And what anticoagulants they'll be on? Or will they be on vitamin K oral anticoagulants or they are direct oral anticoagulant, DOAC, they'll be on.
They'll be on oral anticoagulants.
Oral anticoagulants, warfarin.
They'll be on oral, both are oral only.
Warfarin.
It is direct
Warfarin.
oral anticoagulants or NOAC, they are also called as newer oral anticoagulants, that they are, directly they'll be acting. Unlike your vitamin K antagonists are indirect acting.
Yes.
They block the effect of vitamin K. They are not directly acting, whereas direct acting are dabigatran, rivaroxaban, isn't it? Direct thrombin inhibitors or rivaroxaban is a 10A inhibitor. Isn't it? They directly act. That's why they are called as direct acting oral anticoagulants. So which one will be these patients with a mechanical prosthetic valve will be on?
They'll be on warfarin.
Warfarin, sir.
They'll be on vitamin K
Warfarin.
antagonists. Because vitamin K antagonists are the ones which are can prevent, this prosthetic valve thrombosis. The direct oral anticoagulants are, they may not be able to produce this valve thrombosis, mechanical valve thrombosis. That's why they'll be on vitamin K antagonists. So if the patient is on vitamin K antagonist, posted for an elective procedure, how are you going to manage?
We'll use bridging, sir.
No. First of all, you have to stop oral anticoagulants, isn't it?
Yes, sir. Yes. So we'll stop warfarin. Yes, so we'll stop warfarin 5 days before surgery.
Very good. 5 days before.
And then after 2 days, we will change to either low molecular weight heparin or unfractionated heparin.
No, will you do an INR?
INR and C, sir.
Before stopping? First you do an INR.
Okay, sir.
Because we don't know whether the patient is compliant with oral anticoagulants or not. Just suppose if it is less than 1.5, patient is not taking. There is no question of, going through all these things, isn't it?
Yes, sir.
Otherwise, usually it all depends on what kind of a prosthetic valve. Whether it's a older one, like St. Jude's or Star Edwards is the older one. It requires around 3 INR. St. Jude's is a newer one. It requires just around 2.5. So if he has that, you have to stop warfarin, isn't it? And after 2 days, because warfarin has got 48 to 72 hours of half-life. So you do again an INR. And if it is come down to less than 1.5, then only you start these heparins. Otherwise, you can still, one more day, you can wait and repeat INR and then you have to bridge. Okay. So here, is this patient has got a high risk for thromboembolism?
Yes, sir.
Yes.
Who are all the patients who are high risk of thromboembolism? One is mechanical prosthetic valve. Okay.
Other one is atrial fibrillation, sir.
All atrial fibrillation patients?
Uncontrolled.
Uncontrolled, sir. Fast.
No. You look for Charts VAS score. You have heard about Charts VAS score?
Yes, sir.
CHADS
Yes, sir.
and VASC.
Yes, sir.
That is, C stands for congestive heart failure.
Congestive heart failure.
H stands for hypertension.
Hypertension.
A stands for age more than 75 years and 2 points for that.
Yes.
And D stands for diabetes mellitus, 1 point. And S2 again, stroke. Or if the patient has any TIAs, 2 points. And then VAS is vascular
disease.
Vascular disease. A stands for again age more than 65 years. 65 to 75, 1 point. And SC is for sex of the patient.
Sex of the patient, sir.
So if the patient scores 3 and above, high risk for thromboembolism, you require bridging. So that is what. Or if the patient has already had a DVT and has had a pulmonary thromboembolism, history is there. So patient requires a bridging. But if the patient doesn't have these, only a DVT is there, then the low risk. You don't require to bridge. And if the patient is on DVT and on direct oral anticoagulants, you don't require to bridge. So these things you should know. Okay. And okay, you have stopped and you have started bridging with, ideal would be low molecular weight heparin than direct heparins or unfractionated heparins. Okay. Then
low molecular weight heparin should be stopped 12 hours before surgery, sir.
Okay. No, again, so wait. When you want to bridge, you want to give a therapeutic dose or prophylactic dose of low molecular weight heparin for these patients with high risk.
Therapeutic dose.
Therapeutic dose, not prophylactic dose. Prophylactic dose is once a day. Therapeutic dose is twice a day.
Twice a day.
So, and if it is therapeutic dose, so when do you want to stop?
24 hours.
24 hours, not 12 hours. It is 20.
Hours.
And also give the previous dose half the regular dose. 24 hours before you'll be giving the dose, that should be half the dose. Okay, not the full dose. Okay, then?
It's unfractionated and it's 4 to 6 hours prior to surgery, sir.
Okay, unfractionated 4 to 6 hours prior. Right. That's how you plan. Okay, if the patient is posted for an emergency surgery.
Yes, sir. That case, we can give oral vitamin K if we can wait for 18 to 24 hours, sir.
No, 6 to 8 hours.
6 to 8 hours,
6 to 8 hours.
IV vitamin
6 to 8 hours.
Yes, sir.
Emergency means cannot wait for 6 to 8 hours.
Yes, sir.
IV vitamin.
IV vitamin K, sir. 10 mg.
IV only. Okay, even IV also acts for 6 to hours later. 6 to 8 hours. So you will give vitamin K. What else?
Fresh frozen plasma
Plasma.
of 15 ml per
Kg
kg.
body weight.
15 ml per kg body weight of plasma or
Prothrombin complex concentrates.
prothrombin, that's also available, but very costly. You can also go for PCC. But fresh frozen plasma, 15 ml per kg body weight, you have to give very slowly because you don't want to produce hyperolemia in this patient. It may be about 800 or 900 ml for this patient. So you have to give very slowly. And suppose the INR was 6 in this patient, because emergency, isn't it? You just measured the INR. How much fresh frozen plasma you give?
Maximum 50.
Is it
50
you
ml.
give higher dose or lesser dose? Whatever may be the INR, as long as it is high, the dose of fresh frozen plasma will not change. It is 15
Yes.
ml.
10 per kg body weight.
Yes, sir.
And how much of increase in coagulation activity it will produce? This dose. It will produce more than 30% coagulation. That is more than sufficient to prevent intraoperative bleeding. So that is one thing, again, you may be asked. So patients on prosthetic valves. So this is very, very important. And another thing I asked you, the mitral stenotic patients posted for cervical encerclage. What anesthetic technique you will be using? Patient is not having any valve replacement or anything. Moderate mitral stenosis.
Low dose spinal, sir.
Yeah, you can go for saddle block. Saddle block with some fentanyl, because fentanyl is very good drug for visceral analgesia. The low dose spinal will produce very good perineal analgesia plus the cervical analgesia it produces. So when they are, that may be many times may be enough, but you also give 1 mic per kg body weight of fentanyl also add. So that will produce very good. Or you can, along with the local anesthetic, you can add fentanyl intrathecally only, about 25 micrograms. That will produce very good analgesia for these patients. So when they come for MTP,
IV sedation.
Yeah, IV sedation. But suppose if they are having a mechanical prosthetic valve and you are called as an there in the patient is already lying on the table, how do you manage? There, the gynecologist had not asked about, or obstetrician has not asked about the valve replacement. You go there and definitely you will take some brief history. Patient says that he has had a valve replacement done. How are you going to manage this case?
IV sedation.
You will cancel the case.
Cancel
The
this.
case. Okay, sir.
Yes, sir. INR
Patient has got probably INR of 3.
five.
And if they go ahead and then do D&C, she's going to bleed to death, isn't it? So you'll discuss with the gynecologist, though patient may be, no, these things have happened to me once. That is why I'm asking you. Like many of the examiners might have had this kind of an experience. They'll ask about such things. And the other thing about the induction agent itself, if you're not using etomidate, if you're using propofol, you have to go for a sleep dose. That you should always remember. Sleep dose is half the dose, calculated dose you give slowly, and then 10 milligrams increments because they have a slow circulation. So the arm brain circulation time is prolonged. So for every giving 10 milligrams, you wait for 20 seconds and then give 10 milligrams increments till the eyelash reflexes are lost. That is what you can do. And one more thing, which because of lack of time, it is already I have taken half an hour extra. So if these patients are posted for lap hysterectomy, laparoscopic hysterectomy. So anyway, just read about it, and because I don't want to continue for another say 10 or 15 minutes. Or what we can do is, what is the next case we'll be discussing next week?
Thyroid, sir.
Thyroid, sir.
Thyroid. So just before thyroid, about 10-15 minutes, we'll discuss about this mitral stenotic patient for laparoscopic surgery.
Okay, sir. Okay, sir. Sure, sir.
About 10 minutes, just briefly.
Okay, sir.
That is another common nowadays. Laparoscopic hysterectomy are routinely being done, isn't it? Total laparoscopic hysterectomy or even vaginal
Hysterectomy, sir.
laparoscopic
LAVH.
assisted vaginal hysterectomy. So we'll discuss briefly about that and also lap cholecystectomy in this patient with mitral stenosis and then go ahead. Okay.
Okay, sir.
So I hope not exhausted.
No, fine.
It was a nice discussion and you people were able to answer very well. I'm
Yes,
quite
sir.
happy with the way you people have answered. Okay.
Thank you, sir.
I don't know Dr. Hemant is there or not. Anyway, convey my regards to Dr. Hemant. Okay.
Okay, sir.
So, okay, Dr. Mukhtiar,
Yeah.
thanks for giving us extra 30 minutes to discuss. So everything is recorded, isn't it?
Yes, sir. I'm recording.
Yeah, everything is being recorded. So definitely, if somebody wants, you can share also these recordings.
Sir, I have made Google links, sir. Like I'm adding all the recorded videos to that.
Okay.
I'll share the link, drive links with people, sir. So they
Oh,
can access the videos. I'll
you
share it with you.
also you also give me that link. Let
Sure,
me
sir.
also have that link so that I know how I have discussed, whether I require some improvement in my discussion. Definitely, that will help me.
Okay, sir. Okay, sir.
Okay, everybody. Good night. Thank you. We'll meet again in the next Friday.
Thank you, sir. Thank you, sir.
Okay, right.
Thank you.